Okay. So I originally wanted to just do antiarrhythmics with you guys, because like pharm, there's obviously a lot of pharm this block. But what I noticed was a lot of the times with the antiarrhythmics, it's just quicker to teach them if you like go back through what even is an arrhythmia and like the actual electrophys of like how the SA node conducts electricity to the AV node and whatnot. Um, I will say there's a little bit more detail, especially for the arrhythmias, that you don't really need to know. And I'll try and point it out. Like, I'll try and be like, hey, like, don't get caught up in the details here. It's more so to help you understand how the antiarrhythmics work. Okay, so especially if you're like just confused, you're like, I literally don't, you'll never, like, we're gonna talk about like re-entry circuits and stuff. Like, I think that stuff's pretty confusing, but it really helps, like, oh, why would I give a class 1A for Wolff Parkinson White? We're gonna talk about with Wolff Parkinson White, that's a re-entry circuit, supraventricular tachycardia. So hopefully it kind of like, it'll just help make the antiarrhythmics easier to understand. But don't think you need to like understand reentry circuits and like the actual physics like in that much detail. They're not going to ask about that. Okay, so I just wanted to start with that. There's going to be some stuff in here that are going to be like, I this is not like anything I studied, and that's okay. Okay, so I broke this into two parts because again, I originally just wanted to do antiarrhythmics, but then I thought it would just be a lot better to kind of do a quick review because this is more so where they're going to ask you questions, especially with like how like action like the action potential ions, like they ask tons of questions about that, and then just about electrophys in general. Less so about reentry circuits. This is kind of to like explain what arrhythmias are, and then antiarrhythmics are obviously super high yield. Okay, so just kind of I'll try to go through it like what I don't think is that important quickly, but it's just to kind of give you a basis for the antiarrhythmics. Okay, so this is your physio review. So I'm going to talk about like what automaticity is, high yield electrophys, and then your action potentials. This is really what the questions are like the physio questions are going to be like focusing on. So, quick review. Remember that the cardiac conduction system, they have an intrinsic, like there's an intrinsic conduction. So you don't need extrinsic control, meaning like like you don't need a neuron, like acetylcholine or epinephrine. You don't need that to allow for conduction to start. There is extrinsic control, and I actually have a slide on like I drew out extrinsic control. It's a bunch of the G proteins, but remember that normally it happens on its own. The SA node is known as a pacemaker because it sets the pace, obviously, but it does it all on its own. It's completely spontaneous. Remember the funny current, the funny sodium current? It just completely happens spontaneously on its own. So if we're saying that, like, let's say this example is like like a nodal cell. So this would be like the SA node cell. It's going to depolarize, and then because of gap junctions, it's able to quickly send the signal to like cardiac cells that are located next to it that aren't necessarily nodal cells. Maybe they are nodal cells, but usually it's like to get like the contractile cells. Now that's what's going to it's going to propagate the signal to the next cell. And it's because of these gap junctions, it's able to do this. And that's why like and we'll talk about this a little bit more at the antiarrhythmics. A lot of the times this happens so quickly that it just seems like the nodal cell, so like your nodal cell is going to depolarize and then your cardiac contractile cell depolarizes, but it happens so quickly that it almost looks like these action potentials overlap. But again, it's just because it's happening so quickly. And again, hopefully this will make more sense when we talk about the antiarrhythmic drugs. Okay, so again, you need to know obviously the signal propagation. So it starts with the SA node, then it goes to the AV node, and then it goes to the bundle of His, your left and right bundle branches, and then the Purkinje fibers, and it goes up. Remember that it can also send a signal through Bachmann's bundle over to the left atrium, and that can help with the left atrial contraction as well. And then I think I have it on here later, but remember Purkinje fibers are the quickest, and like the AV node's the slowest, but we'll talk about that a little bit. So if we kind of zoom in on this a little bit more, what does it mean? Like it's not just a circle and then it like sends signals in all different directions. It's a bundle of cells, and there are both contractile cells and then autorhythmic cells, and these are what your nodal cells are. So this is what I'm talking about. There's two different action potentials because there's two different types of cells that are located like all throughout the heart. So I have the autorhythmic cells in green, and then the contractile cells are in gray. So let's say this cell is going to spontaneously depolarize again because of that funny current. It spontaneously depolarizes. That's going to bring it up to the threshold, and then once the threshold hits, calcium channels open. When calcium channels open, now basically you get what's known as that functional syncytium, because again, we don't want the heart beating like at random time. Like we don't want each cell beating at a different time. So all of the nodal cells are going to depolarize at once. And then this is what's responsible for the true upstroke, that sodium channels opening and contracting the actual heart. So once we have one cell that depolarizes, then all the nodal cells depolarize. That's your functional syncytium. And then the true upstroke, the beat, is going to be the depolarization of the contractile cells. And then kind of zooming in a little bit more, another really important concept that's going to come up a lot with the antiarrhythmics, especially the class 2 and class 4s, like some adverse effects of class 2 and class 4s, is if I kind of like take this out and just we look at it like this. So SA node, Bachman's bundles, of course, left atrium, goes to the AV node bundle of his, left and right bundle branches, Purkinje's. Right here at this AV node, conduction velocity slows down a lot. So it slows way down. I can't remember how I took this out of your guys' PowerPoint, so you might have the answer there. But without looking, why is it like so important that conduction slows down through the AV node? Does anyone remember?
Maybe because it is the connection point between the atria and the ventricles.
Yes. So, right, exactly. So, Lexi, good. So, Jay, 100% correct. It's kind of like the SA node can't get to the ventricles without going through the AV node. It's like it needs to go through that. And it's really important to slow it down because we need the ventricles to fill here. So the only node, and this is kind of what you guys both said, the only node that allows the atria to depolarize the ventricles, so that delay is crucial for ventricular filling. So this delay, you can kind of think of like the delay through the AV node as like giving the ventricles, or the atria time to fully contract to allow the ventricles to fill before the ventricles contract. Because if the ventricles are contracting before the atria are even done, you're not getting as much blood out. And this is also why this is all, So if we talk about how before I go into this, sometimes like they'll talk about how like athletes are like have really, really like slow heart rates. Like Jay, your resting heart rate back when you were playing soccer is probably like 40. My brother, same thing. My brother, he played college football. His resting heart rate when he was playing college football was literally like 41 or 42 at all times. Normal heart rate's like 60 to 100. It's not because it's anything bad. It's because the body is like, oh, it's like an adaptation. The body's like, oh, here's this athlete. He needs to pump out tons of blood all the time because his organs always need oxygen. So we're actually going to slow conduction out through the AV node. So every single beat, every single time blood beats out of the heart, more of it is beating out. So it's kind of like an adaptation that athletes face, but this also obviously increases the risk for heart block, which we'll talk about. A lot of some of the antiarrhythmics, like I said, the class 2 and class 4s are notorious for slowing conduction through the AV node, and adverse effect of your class 2 and class 4s is heart block, and that's why. It's because they slow that conduction. Just want to point that out so it's like less to memorize. But let's say you speed up conduction through the AV node, because we're going to be talking about arrhythmias first, right? Like we're talking about arrhythmias, we're talking about electrophys. So if something happens where now conduction velocity is sped up, so this happens quicker than it should be. So now the AV, again, the ventricles are contracting before the atria are done. You can imagine there's going to be decreased stroke volume, and ultimately this is going to lead to decreased cardiac output. So there's something that the body has in place. It's called overdrive suppression. And this is just to kind of, again, emphasize that the nodal cells are not only in the SA node. There's nodal cells in the AV node. There's actually nodal cells in the bundle of his and the Purkinje. There's nodal cells everywhere in the heart. And these are known as latent pacemakers because they can also undergo the funny current. So they can also depolarize. And the idea there is like if the SA node stops working or it gets like beat up somehow, the heart is not gonna stop beating. So there's these other pacemakers. I'm sure you guys remember studying this last year. But there's this concept, overdrive suppression, is like the SA node's the fastest. So the SA node is the pacemaker. It's the one that's controlling the heartbeat. And while it's the pacemaker, the other pacemakers are suppressed. But if we have this thing happening where if the SA nodes aren't firing, then we have an ectopic pacemaker. So any of the other nodal cells in these other locations can become the new pacemaker. So that's what's known as an automaticity foci. Again, this is like to help understand arrhythmias. This is not like a memorization type of thing. But again, kind of remembering SA node, there's overdrive suppression because it's in charge. But again, if it for some reason doesn't work or it stops beating correctly, there are these latent pacemakers elsewhere. So the first one that kind of kicks in afterwards are just other atrial foci. So like not the SA node, but other foci in the atria. Then there's the AV node can kick in. So the AV node can kick in, that's your junctional foci. And then there's ventricular foci. So literally bundle of His, Purkinje fibers, they can also do it. And these are located in the ventricle. So just wanted to point that out because, again, a lot of the arrhythmias can happen because the SA node stops working and then these other pacemakers take over. All right. Action potential generation, so excitation, contraction, coupling. This is probably the most high yield. This is like a need to know. I put tons of slides in here to kind of really hammer this in because this is where you get questions, especially on boards, because it's physio, right? It's cardiac phys. They love that. So remember, action potential gets generated. Remember, it's intrinsic and extrinsic. Intrinsic is your funny current. This is your automaticity. This is all that stuff happening. Extrinsic is like your nervous system, like sympathetic, parasympathetic. This is like your G proteins. Okay, we talked about that. So basically, the same thing is happening, whether it's intrinsic or extrinsic. You have the same result. It's just the trigger is going to be different. For intrinsic, it's your funny current that triggers a whole set of stuff. Extrinsic, it's like you have a beta-1 receptor that gets activated, G-alpha S. You have G protein propagation. So I'll show you it, but it's the same thing that's happening, nodal cell to contractile cell. It's just like the difference is how it starts. So that's what we're going to talk about now. We're going to review kind of this stuff really quickly. So your SA node action potential, this is a need to know. This is also like when you'll see with the antiarrhythmics, this is what they'll ask questions about. They're like, what's happening to like phase 4 of your SA node if you give this antiarrhythmic versus what is the action potential of a contractile cell going to look like if you give like a class 2 or a class 3, which we'll talk about, but you should 100% know SA node action potential looks like this. Phase 4 is that funny current, and then you have your calcium upstroke, and then your repolarization with potassium. Contractile cell, the upstroke is because of sodium channels opening. Then you have potassium channels start to open, but then you have calcium channels as well. That's kind of what's responsible for your plateau, and then full-on repolarization with just potassium. Okay. So I wanted to kind of show you like in real time what was happening intrinsically, because again, it'll really help with the antiarrhythmics, like seeing the physical channels and like, of course, going into a little bit of the molecular bio. So the first thing that's going to happen, so remember, your nodal cells, I had them in green, and then your contractile cells, I had them in gray. And I'm going to also talk about phospholamban a little bit because just with like other drugs. But okay, so we have our nodal cell. The first thing that's going to happen is we have spontaneous depolarization of our funny channel. So again, this is just your sodium is just coming, it's just leaking in through these funny currents. Resting, we're at negative 60 millivolts. Some are going to come in. This maybe shoots it up a little bit to like negative 55 millivolts. And then this is going to open your T-type calcium channel. So T-type calcium channels open. Now we have more positive within the cell. This is going to bump it to maybe negative 40 millivolts. Then your L-type calcium channels, your fast calcium channels are going to open. Calcium's going to flow in. And now we have our millivolts are going to shoot. Now we have all these cations within the cell. The millivolt, they're going to flow through to the contractile cell. And then this is going to basically trigger the contractile cell to go from negative 90 to negative 70. Okay, at rest. And this is happening so fast. But I just wanted you guys to kind of see this visually because this is how the gap junctions play a role. So then the fast sodium channels open, sodium flows into the cell. Now we're at that upstroke, right, of that. So like, again, with those action potentials, this is that one, and then this is like this one. So we're here currently at phase 0 with the sodium channels flowing in. More calcium flows in because now we're kind of like at that plateau, as well as potassium channels open. Like all this stuff is happening. Now we're at positive 10. When it becomes positive, your sodium channels close, your potassium channels open as soon as it hits that positive. So potassium is now going to leave the cell, and then we're back to basically 0, and then all this stuff keeps happening. Calcium flows in, potassium flows in. We're at the plateau, right? We're plateauing, and then eventually it's just basically, calcium goes through the T tubules, whatever, calcium keeps flowing in. Calcium can also bind to this ryanodine receptor. So see the RYR2 receptor? This is your ryanodine receptor. Ryanodine receptors, once it's bound by calcium, this is going to be a trigger. to now have calcium that's located within the sarcoplasmic reticulum to leave. So this is called calcium-induced calcium release. So I'm going to go back because it's really important for contraction. So calcium kind of flows in through the T-tubules. It flows in through the receptors. It binds to the ryanodine receptor. Remember, there's an entire page on first aid, but it's helpful to see it. So calcium flows in, binds to the ryanodine receptors. Now calcium is telling the sarcoplasmic reticulum, hey, release calcium. So that's going to cause calcium to be released, calcium-induced calcium released. When calcium leaves the sarcoplasmic reticulum, it's going to bind to troponin C, because troponin C stands for calcium. That's going to basically cause tropomyosin, this orange line, to move out of the way when calcium binds to troponin C. Tropomyosin moves out of the way, so now actin and myosin can basically bind to each other. Oh, I didn't animate that. So actin and myosin can now bind to each other, and we can get like a stroke. Okay, so that's basically all that's happening in that like millisecond of this contraction. So now what has to happen is we have to repolarize the cell. So first thing that happens is potassium's going to leave. The potassium channels close. These calcium channels close. All sorts of things are happening. And now we need to kind of resequester calcium back into the sarcoplasmic reticulum. So calcium is going to go through this calcium hydrogen ATPase. So ATP is used to pump calcium back into the sarcoplasmic reticulum. And then, as well as at the same time, we have calcium being exchanged with sodium right here. And if you guys can remember, this is actually how digoxin kind of works. Digoxin, it doesn't block this receptor, it blocks your NAK pump. But by doing it, there's less sodium available for this calcium and sodium exchanger. So if there's not as much around, more calcium stays in the sarcoplasmic reticulum, so more calcium can leave and bind to like the troponin C, and then you can get a more forceful stroke. So again, just trying to tie in some pharm anywhere I can. And then we keep getting more repolarization. Potassium's going to leave. This goes back to -90. And then this goes, well, I missed it from earlier, but this goes back to its resting potential. Okay? So that's kind of what's happening when I talk about, no, I'm not going to do that. When I talk about this SA node depolarizing and this contractile cell depolarizing, this is what is happening within the cell. Well, yeah. Okay, so this is your this is intrinsic, beating of the heart. And it happens, again, whatever pace the nodal cell that's in charge decides, that is going to be the pace. But if you're exercising, obviously you need a little bit more than what the nodal cell can give you, and that's where extrinsic kind of comes into control. So I didn't want to do this. This took a very long time to make, so I just drew it. But basically, same thing, nodal cell, contractile cell. At this point, you can look at, it's the nervous system, right? So what's going to happen is like a sympathetic nerve is going to release norepinephrine and epinephrine. You know that those guys are going to bind to beta-1 receptors on the nodal cells. So it's going to bind to beta-1 adrenergic receptors. We're going to talk about where else beta-1, specifically beta-1 receptors are found. They're also found in the juxtaglomerular apparatus and the kidneys. So epinephrine can bind to beta-1. It's coupled to a G-alpha-S, so we get a GS stimulation. Adenylate cyclase is going to convert ATP to cyclic AMP. Now protein kinase A gets activated. Protein kinase A is going to activate those L-type sodium channels on the nodal cells. So we're kind of bypassing that bunny current. It's kind of like, hey, I need those L-type calcium channels open. That's going to basically enter the cell now, and now we have this increase in calcium potentials, which is going to increase basically just the action potentials, which is going to increase your heart rate. This is kind of your tachycardia. So that's kind of how like the sympathetic nervous system acts. It also acts the same way on the contractile cells. It's just instead of acting on those L-type calcium channels instead of only acting on the L-type calcium channels on the surface, it's also going to act on those calcium channels on the sarcoplasmic reticulum. Okay, so it's going to both agonize those receptors as well as the L-type calcium channels on the surface. So more calcium than normal is going to flood in, and then you're going to have more calcium ready for a contraction. So you increase stroke rate, increase volume. So does SNS override regular nodal cells? Do they have? Yeah, good question. Yeah, so it kind of overrides it. So it'll increase the SA node. It'll increase the SA node's pacemaking, basically. Mm-hmm. So it's kind of in charge. As soon as extrinsic kicks in, that's in charge now. And then similarly, so, you know that it's not just like the absence of sympathetic nervous system that lowers your heart rate. It's like the active turning on of the parasympathetic nervous system, and specifically it's the vagus nerve for the heart. Remember, the vagus nerve is the heart and lungs, and pretty much all the GI organs before like the level of like T10 is the vagus nerve, and then it switches over to like the other parasympathetic nerves. But regardless, we're not talking about that. So acetylcholine gets released. Acetylcholine binds to an M2 receptor, so it's muscarinic 2 receptor, and if you remember your G proteins, that's coupled to a GI. So if we're coupling to a GI, not only are we just basically inhibiting adenylate cyclase, because remember from G proteins, that's what the alpha I G protein does, it inhibits adenylate cyclase, but you're also getting more repolarization basically. So remember, G proteins are heterotrimeric, so there's alpha, beta, and gamma. The alpha subunit blocks adenylate cyclase. Beta and gamma subunits are actually going to cause the potassium channels to open so that potassium can leave the cell, and now we're trying to go back down to like normal action potential. Okay. Ooh, and then the same thing obviously happens. I think I just got lazy and didn't draw it, but the same thing can happen over here in this contractile cell as well. And then wanted to talk about phospholamban because it does come up like every now and then, but phospholamban is basically this protein here. I drew it on this guy. It's right here in gray, and it basically controls how much calcium can leave the sarcoplasmic reticulum. So let's say that we have sympathetic activation. So we have sympathetic activation that's happening. So cyclic AMP is going to increase. We have PKA that's getting activated. And this is where it gets kind of confusing with like terminology. When PKA is active, it obviously phosphorylates stuff. So I'm like talking about here, it's phosphorylating this calcium channels, opening up these calcium channels, opening up these. It's technically phosphorylating phospholamban. And what that does by phosphorylating phospholamban, it's actually going to stop SERCA. SERCA is normally inhibited like this. If we phosphorylate phospholamban, SERCA is no longer inhibited. So SERCA is that calcium ATPase, basically, which is over here. So I drew phospholamban the wrong side. It's all right. So normally SERCA is inhibited. Phospholamban is controlling it. Normally it's blocking it. And as soon as we phosphorylate it, and this is like one of those things, and you'll learn this with like some of the viruses do this. When you phosphorylate, it actually like it activates it, but it's taking away an inhibition. It's just like a weird terminology. So it normally blocks, we phosphorylate it, no more inhibition, and now calcium can be brought into the sarcoplasmic reticulum. So literally like you don't have to know all these names, but just kind of wanted you to visually see that. If we don't have phosphorylation of phospholamban, and I put parasympathetic here in parentheses because like acetylcholine is not doing this. It's just not having cyclic AMP, like an active PKA is doing this. So this is normal. So you can think of this as just like normally, it's more of like a parasympathetic, because we don't want the heart to be contracting it like very hard if it doesn't need to. That's why your normal pacemaker cells don't really need much help from phospholamban. So what happens here is like inactive PKA, phospholamban is completely blocking SERCA, so there's no phosphorylation of phospholamban, so it's blocking it entirely, and now calcium does not flow into the sarcoplasmic reticulum, and now there's less calcium for the next contraction. So this is kind of how, like, if you're exercising, this is another thing that protein kinase A can do with exercise to kind of override the normal pace. So we can have more calcium ready in the sarcoplasmic reticulum that can then be ready for the next contraction. So it can just help you increase your stroke volume and increase your cardiac output. Okay, and again, wanted to tie it in with digoxin. We are going to very briefly talk about digoxin because it's considered like a class 5 antiarrhythmic. This is not an antiarrhythmic function of digoxin. This is the normal function of digoxin. It's usually given for heart failure. And just wanted you to know digitalis and digoxin are the exact same thing. They're not even like precursors of each other, like they are used interchangeably. So digoxin, digitalis, whatever, what it's doing, so we're now in like basically where the sarcoplasmic reticulum is of a contractile cell. So we're basically here, and this is where digoxin works. What it does is it's going to block this NAK pump, and when it blocks this NAK pump, there's basically more sodium now there's more sodium available now for this calcium sodium exchanger. So if there's more sodium available here internally, now more of it can be brought out and more calcium can be brought in. And if we have more calcium being brought in, as you've been seeing, that's going to increase the amount of calcium that can bind to troponin C. And when you have more calcium binding to troponin C, tropomyosin moves out of the way, actinomyosin can bind more strongly. That's your increase in inotropy. It's increasing the strength, and it's really important. It's not chronotropy, it's inotropy. And if you need a little physio reminder, inotropy is your strength of the contraction. The heart is beating stronger because there's more calcium. That's very dependent on calcium, how strong the heart is beating, which is really good for heart failure, right? Where like the heart's not beating that great, or it can't beat that strongly. It actually decreases chronotropy, and this is like the part I'm going to talk about later with its antiarrhythmic function. This is its antiarrhythmic effect. It's actually going to increase the amount of parasympathetic stimulation that goes on the heart. So it's going to increase basically this here. So it's going to increase this is going to increase how much parasympathetic nervous system goes on the heart, but specifically through the AV node. And again, a lot of the antiarrhythmics work specifically through the AV node. So that's going to increase your PR interval. You're basically trying to induce heart block, and that's why you can give it as an antiarrhythmic function. So digoxin increases inotropy because of this, but then it's actually going to decrease chronotropy because you're slowing conduction through the AV node. And again, chronotropy is just how quickly the heart is beating. And that's again why it's like a class 5 antiarrhythmic. But we will talk about digoxin with like its antiarrhythmic function when we talk about antiarrhythmics. Surprise questions. Okay, so before we go into part 2, I really wanted to emphasize the ions and stuff because that's going to be like a lot of your questions. That's all right. May, you can go sleep and watch this when you're feeling better. I feel bad. So this is a myocardial action potential. So this is usually when they're talking about like cardiac muscle cells, those are your contractile cells, not your nodal cells. Okay, okay. Good. You guys all got it. Beautiful. Good. So awesome. And I'm telling you, there are so many questions like this. Like you block outflow of potassium, you block inflow of sodium, you block calcium, and they always ask about this type of stuff. So good. Good. All right, next one. And then this one, Lex, for example, like you have to know if I look at this action potential, which action potential are they talking about with the shape? So sometimes they won't tell you. Oh my God. Awesome. Great job, guys. D, good. So I actually like this question because this is actually how a lot of the antiarrhythmics work. And it shows about how like it manifests on QT, like on the EKG, which we'll all talk about, but awesome. So again, potassium channels on a nodal action potential is that. Again, this is like your funny current, calcium, and then potassium. Okay. Last question before we move on. Haha, Jay and Lexi, you guys got. Nay, oh, you didn't get it right, but you didn't get got, so I am proud of you. I am proud of you. You didn't get got. So I really wanted you guys. Okay, yes, go ahead again. Go ahead again. But this was a quick knee slapper one that I don't want you guys to get wrong in the exam. Yeah, everyone try one more time.
I'm just confused. Like, it's not inhibiting the calcium channels. It's just like, I don't know. It's inhibiting
Right. What's
that.
it doing? So tell me what it's doing. So tell me what the antiarrhythmic effect of digoxin is, because you guys both picked this, which is its heart failure effect. That has nothing to do with the PR interval. Remember, that's like for heart failure. That's you're trying to increase stroke volume, cardiac output. But it also causes basically like a heart block. It increases the PR interval.
Boo. Boo. It's C. Boo.
Yes.
That's such a boo question.
This is such a good question. I love this question. I'm gonna bring this question up right before I'm gonna send it to you guys just randomly before your exam. Be like, answer this question again. Does that make sense though? Aw, don't you guys are gonna love me. Don't worry. But don't get got with digoxin. Do not get got with digoxin. It has two effects. One helps with the inotropy. This is 100% correct. Like this is what digoxin does. It does inhibit this NAK pump. But doesn't that has nothing to do with the PR interval. That's not its antiarrhythmic effect. Its antiarrhythmic effect is it basically acts like it's increasing parasympathetic stimulation on the AV node, which is it's basically trying to induce heart block. And that's what a lot of the antiarrhythmics are doing to try and like get the heart rate back into normal rhythm.
But also, they don't really ask what the effect like of it prolonging the PR interval is. They just say, "What's the effect of this drug?" The observed effect, it did. You can observe that it blocks the NAK plus.
That's fair. That's fair. I guess they don't talk about how like cardiac output increases or like stroke volume increases or ejection fraction increases. They're talking about the PR interval.
Yeah, they should say, "What's the effect on the PR interval?"
They probably know that that's going to give it away. This is what boards does. Your exam probably won't do this, but this is what boards does. Boards loves to do this. And you're like, what are you talking about? This is right. This is 100% right. And just like you said, it's not like inhibiting the calcium channel. It's not doing that. It's just increasing the amount of parasympathetic stimulation on the AV node, which is going to just like not allow for sympathetic stimulation to occur. Same thing with this. This is also getting, oh no, this is not getting activated. So this is not what's happening. And with this too, like you're not really getting a decrease in cyclic AMP, you're just not getting cyclic AMP. Yeah, I know that's what you were doing with the AV node. I know like you were like, oh, it's gotta be AV node because of the PR interval. This is just not what's happening. Usually it's just like that parasympathetic stimulation just increases. And again, we're gonna talk about that with beta blockers, calcium channel blockers. They both do this. They both increase vagal tone on the AV node. They're basically trying to induce a heart block, a first degree heart block, which is a prolongation of the PR interval. Yeah, it's a good question. It is a good question. I'm glad you see my side now. The other thing I will say about the other thing I will say about digoxin that they really like you to know is hypokalemia is a huge side effect, and again, it's because of like Jay, you know it's a good question. But the reason why is because like they like to ask like, oh, which of the following is an observed like side effect of digoxin? Because this is literally like a physiology question. It's blocking the NAK pump. So you're like, well, what does that mean? Remember that keeps sodium in the cell, like in the sarcoplasmic reticulum. It just keeps it in there. So now more can be blown out for calcium to come in. So with that being said, since you're blocking that pump, you can see hypokalemia. They love to ask about that. I had a question about that on boards, I think on both sets of boards, and I think on the exam they even asked like what's a side effect of digoxin, and it's hypokalemia. And then just understanding how that's what they also say here, like understand how hypokalemia can present on an EKG. You know, like you can get like a U wave, right, with hypokalemia. But it's all in the sketchy. It's all in the sketchy, so they'll talk about that. Okay, good. Makes sense. We love it. We love physio. Okay, I'm gonna go a little bit quicker through the I'm gonna go a little bit quicker through arrhythmias because again, this is like I'm gonna talk about reentry circuits. They're really not important. I just want to kind of help you understand the antiarrhythmics a little bit more. So I'm gonna try and go through that a little bit quicker. Don't get caught up in the details. This is really important. So these refractory periods. So back to good old Costanzo. Remember ARP, ERP. So your ARP, this is your absolute refractory period. So we're talking about the contractile cell. It's the contractile cell action potential. And remember, a refractory period is like you cannot get another action potential if you were to get a stimulus if you're within this period. So the absolute refractory period is the cell absolutely is unable to fire another action potential. Doesn't matter how strong of a stimulus you give it, it does not matter. Most, if not all, of the sodium channels are closed within this absolute refractory period bar. So if the sodium channels are closed, it can't carry that inward current. You just can't do it again. Like you can't stimulate it. When you get to the effective refractory period, which doesn't seem like much, it's only like this much, but it's really important because this is literally when the sodium channels start to open again. And of course, we're not getting another action potential right away, but like if you were to give it a strong enough stimulus, you technically could open it with the effective refractory period. But like I say here, there's still not enough of an inward current to conduct to the next site, like to have another action potential. But it's there, like the possibility is there. And that's what I want to emphasize. A lot of the drugs extend the effective refractory period. That's like a thing that they do is they extend the ERP. And the whole idea of that is because we don't want the body just sending out another, especially if you have an arrhythmia, we don't want the body to send out another action potential. It doesn't have to. So it's good to like kind of extend that period. Okay. So just understanding like sodium channels are closed, doesn't matter. But here they start to open a little bit. So you technically could. So let's extend that a little bit more. Let's try to make it let's take it like longer. And that's a basis of a lot of the antiarrhythmics. And then relative, this is more so just terminology because it will come up. Your relative refractory period, same thing. It's just like the next step after effective. So like even more have recovered. You can generate another one. It's kind of the same thing. But if you were to generate an action potential during this period, you would get like an abnormal configuration. It would just look weird. Again, a lot of arrhythmias can happen by starting it in the relative refractory period. And then your super normal period, this SNP, this is like the threshold is lower than typically required to generate an action potential. I only bring this up because some of the things we're going to talk about is like after depolarizations and like ventricular after depolar and like what is an after depolarization. It's basically an action potential that gets generated like at one of these spots. Okay. So back to this. I do think actually now that I think about it, I think Scally asked a question about after depolarization. So I did want to keep that in here and talk about that. So abnormal conduction, automaticity, again, the basis of arrhythmias. So what does that mean to have abnormal conduction when your electrical activation is not equal to what's supposed to happen? Like the SA node is not going to the AV node to the bundle of hit. It's not beautiful and happening nicely. Something's going wrong. So usually it's because of ischemia. So usually it's like, these are all tracks, right? It goes from SA node to AV node to bundle of His to the fibers. Like these are all like tracks of electricity. These can get like damaged with ischemia or they can get damaged with like other stuff. Usually the AV node, because again, the AV node is the most important node in the entire conduction pathway. I will go to bat for the AV node. So if that gets damaged, that's really not great. So ischemic damage can kind of trigger this. Excessive vagal stimulation can trigger this. Like even your athletes can kind of, that's why heart block can happen, right? Because it's like it's excessive than what's normal. You can get bundle branch blocks. So bundle branch blocks, the bundle branches get blocked, or they get like, there's ischemic damage. So now it's like there's reduced contraction efficiency, or there's just delays. You can get ectopic beats. Again, if the body thinks that the SA node's out, the AV node's out, the bundle of His nodes are out, you can get the ventricular foci. Now that there's no overdrive suppression anymore, they can start firing. And that's going to give like really weird beats happening, like just extra beats. And that's an arrhythmia. But basically, abnormal action potential generation is a cause of pretty much all of the arrhythmias. There's abnormal automaticity. It's known as triggered activity, which I'll show you. That's kind of like your reentry currents, and then that's causing your tachycardia. Okay, so abnormal automaticity, this is kind of what I was talking about in terms of like you don't need to know this details so much, but just thinking about the terminology. If I have reduced automaticity, that means my SA node is firing less than normal. So I'm going to see bradycardia. And typically what causes that is your hyperkalemia. Hyperkalemia causes bradycardia. Just like, think about it. If I have so much potassium, like I'm basically kind of going to, I'm basically not going to allow repolarization to happen like effectively. So it's like the next beat takes a little bit longer to come into fruition. You can have enhanced automaticity. This is your tachycardia. This is a lot of the arrhythmias have enhanced automaticity, and that's where you see your tachycardia. Usually it's hyperkalemia causes this, but there's other things. Increased body temperature. Hyperthyroidism increases your body temperature. It also increases your body temperature. Think of hyperthyroidism, and that's what's happening. So triggered activity, this was actually the question on our exam, was what these were. I don't know if it's still going to be on there. It's 3 years ago, but just wanted to put these on here. So triggered activity, again, this is because something gets triggered during one of those refractory periods. Those are known as like after depolarizations. They're spontaneous depolarizations happening after the cardiac myocyte was already depolarized. So you can have early after depolarizations, or EADs, or you can have delayed after depolarizations, or DADs. So early ones happen, you can see it in this picture here. Early ones happen around phase 3. So it's like when the potassium channels start to open. You can see those, or close. You can start to see those, and that's when the action potentials are going to be a little bit prolonged. So again, you can imagine these happening if you have like a hyperkalemia. You can see like it can get spontaneously depolarized. Or you can have a delayed one. Usually this is going to be because calcium is elevated. So calcium is elevated for whatever reason. The patient can be on digoxin. They can have ischemia, excessive catecholamines. Anything that's going to cause calcium to increase can be a trigger for a delayed after depolarization. But that's all it is. It's a depolarization happening within one of those refractory periods at various phases, and like the action potential that just happened. Hopefully that makes sense. Don't dwell too much. It's more of like a terminology thing. If you see these terminologies, that's all they're talking about. And of course, these can then trigger an arrhythmia. Because again, arrhythmias, anything that's just not normal can trigger an arrhythmia. All right. Some physics, apologies, but we are going to talk about this a little bit because of explaining the antiarrhythmics. So reentry circuits are like your number one cause of generating a tachycardia. So what's causing like an early after depolarization, or even just a tachycardia in general. So normally what happens, and this is from Klabunde, I'm pretty sure. I had to go to Klabunde for this one. So normally what happens, you can imagine like this is like where the AV node is, right? And I don't actually know if that's where this is happening, but just to kind of like to visualize it. And then it gets to the bundle of His, and then it branches right into your left and right bundle branch blocks, or bundle branches. And it has to happen at the same time because we need both parts of the heart to get, like the Purkinje fibers need to like send that electrical signal to both parts of the heart at the same time. We need the heart beating at the same time. So what can happen is, normally what happens is here, this red line is like your electrical signal. So this is going to come down, it's going to split, right? So bundle of His to the bundle branches, it's going to split. And then over here, this is what's known as excitable tissue. So this is going to be like this star, this is excitable tissue. This is allowed to now, like basically this can generate a beat, like this can contract. And I know it's kind of hard to visualize it. I really don't think there's a better way to kind of explain it. But once it comes down and like it goes through like the Purkinje fibers, and now the heart contracts as like that functional syncytium, now we can have our contractile cell, our action potential is going to happen. But what you can notice here is because it splits, it can actually come back together. So this is what's happening here. It can also come back together on both sides. But since that's happening, they cancel out. So these guys cancel out, which is good. That's normal. We want them to cancel out. We want the left ventricle to get activated at the same time as the right ventricle. We don't need it to go back. Like we don't need the left-sided electrical potential to go activate the right side. Like that's why we have bundle branches. But what can happen with arrhythmias, and especially with these reentry circuits, what reentry circuits even are, is basically we have the same thing happening. We have this conduction of a contractile cell action potential, but then we have what's known as like a unidirectional block. So a unidirectional block, usually this is because of like ischemia or something. So you can see like the gray tissue. It doesn't allow this electrical current to go through, like, let's say the right bundle branch. So this is your bundle branch block. This would be like an example of a bundle branch block. It's a unidirectional block. It doesn't allow the signal to go through. So what happens is when this splits, we start off with a normal looking contractile cell action potential. But now this other, like when the electrical potential splits, nothing stops it. There's nothing to kind of block it in its path. So it keeps going. So it's gonna go, it's like, all right, let me go activate the right side. Like I'll just keep going. But then it can keep circling through. It can go back through, and that's what's generating what's known as a reentry circuit. That in this instance, this is generating an early after depolarization. And this would just go over and over. That's why they call it a reentry circuit, because it's going over and over and over and over again. So this is usually why like this partial conduction block, it's not blocking it in both directions. It's only from the signal up here to down here, but it allows it to go through this way, and that's what's causing these after depolarizations. Okay, but this is where I talk about here, like let's read. So cyclical reactivation, that's kind of the idea of a reentry circuit. The tissue has to be excitable. So what I mean by this is it can't be in a refractory period. If it goes through here like this, but it's in a refractory period, it's not going to excite. Remember, like that's the whole point of having these refractory periods. It doesn't matter how much signal it gets. It's not going to depolarize again if it's not ready to be depolarized. So that's why timing is really important, and that's actually why a lot of the antiarrhythmics try to extend refractory periods. They're trying to make them longer, so even if there is an arrhythmia with a reentry circuit, it's not going to stimulate and give like an after depolarization like this. This is kind of what we just talked about. Same thing. So normally comes through, goes through the AV node, bundle of His, whatever, left and right bundle. So this would be like a reentry circuit within the AV node. You can have them anywhere, and that's what I'm saying. Like this, like I said, like this is bundle of His and the bundle branches, and this is bundle branch block. It doesn't have to be. It can be the AV node. It's anywhere along the electrical circuit. So the impulse is coming from the SA node. Here's the AV, and then it goes through the AV node. Then it goes to the bundle of His pathway, and then we have the ventricles. Don't worry about like the slow pathway, fast pathway. It doesn't matter. It's normal. It is normal. But if we have ischemia, we have something happening where it's causing like a unidirectional block in one direction, you can just have over and over and over. Some of it will still get through, just like here. Some of it still, let me get rid of this stuff. Some of it can still go through and go do what it needs to do, but you're going to have this reentry circuit over and over and over again. And that's kind of what this is showing too. Like some of it's going to get through and it's going to go do what it needs to do. It's going to go depolarize the ventricles, but it's going to happen quicker than normal because of this reentry circuit. And that's kind of what can cause like a tachycardia. And then kind of going into reentry circuits, because Wolff-Parkinson-White is a specific type of reentry circuits. This is just saying like everywhere you can have a reentry circuit. It's, again, like I said, it can be anywhere along the electrical conduction pathway, but there's like two main ones. There's like a global and like more of a localized one. So I'm going to talk about like global reentry. Global reentry, just think of the whole heart. Like we have a reentry circuit happening between the atria and the ventricles. So what happens here is through the bundle of Kent. So there's a bundle of Kent, so it bypasses the AV nodes. Remember, it goes SA to AV to bundle of His to the Purkinje fibers, blah, blah, blah. There's also what's known as a bypass tract, and that's through your bundle of Kent. That's like you should probably know that. You probably studied that last year. Goes through the bundle of Kent, and then it can stimulate the ventricles if it's ready and if it's excitable. So that's what we call it, AV nodal reentry. So AV, you might even see like it causes an AV nodal reentry tachycardia, an AVNR tachycardia. That's what they're talking about. It's going through this bypass pathway through the bundle of Kent, and then it just goes over and over again through the AV node and back through the bundle of Kent, through the AV node, back through the bundle of Kent. So that's called AV nodal reentry. And since it's through the atria and the ventricle, because it's the reentry pathway between the atria and the ventricle, that's known as a global reentry circuit. And this is what a lot of the supraventricular tachycardias are, like Wolff-Parkinson-White. Wolff-Parkinson-White is this is actually exactly what happens in Wolff-Parkinson-White. We have this bypass pathway, and then for whatever reason, it just keeps going. It gets triggered over and over and over again. So my question here is, and you guys don't even have to answer it, I think it's on the slide, but just thinking about this type of reentry circuit, what would then be a good antiarrhythmic for something like Wolff-Parkinson-White? And the answer for this is anything that's going to extend your extended refractory period. Anything. So anything that's going to extend because again, you can't, even if this were to go back through and circle and over again, it doesn't matter if you don't reach excitable tissue. So if you're extending the refractory period, making it like impossible to generate another action potential, even if you come across like our reentry circuit, it's really not going to do much. So that's why it's really good to extend the effective refractory period. A lot of the antiarrhythmics do that. Or since this is a specific AV nodal reentry circuit, you can actually just further depress the AV node, make it go even slower than normal through the AV node. So then by the time it reaches the next thing, it'll be time for the next beat. Okay, so this is what your beta blockers try to do, your calcium channel blockers do, and adenosine, your class 5. We'll talk about adenosine. 1C extend ERF. 1Cs actually don't extend ERF. It's really just your class 3s and your class 1As. But we'll talk about it. Class 1Cs are really good at blocking your sodium channels, but they really don't tend to have an effect on the effective refractory period, which is very dependent on your potassium channels. And again, we're going to talk about all this with the antiarrhythmics. Just kind of wanted to show like look, it's relevant. It's relevant. It actually does what it's supposed to do with these reentry circuits. But just kind of thinking like, oh yeah, if I extend the effective refractory period, I'm going to, like, even if there is a reentry circuit, it's not going to matter. It's not going to come across excitable tissue, and then the arrhythmia should stop. Because again, this reentry circuit, that's what's causing the arrhythmia. So if you come across non-excitable tissue, it's done. And it's not to say it can't keep happening over and over again, but if you're on an antiarrhythmic, it's usually going to like stop it for the time being until you can figure out like what's going on. You can also have, again, like I said, global or local reentry. A local reentry circuit, it's the exact same thing. We have reentry of like like an electrical potential, but now it's in like a very small region of the heart. So it's usually going to be in like the atrium, or it's going to be in the ventricle. So an example of a local reentry arrhythmia is like an atrial tachycardia or a ventricular tachycardia. Those would be like, here's a local reentry circuit in the atria. You can have one down here. Again, they're possible. They can happen anywhere that the electrical conduction pathway goes. Okay. But it's a small region, and then these themselves are not bad, like having these local reentry circuits, those themselves are not bad. They become bad when they can then precipitate like a VTAC, which is like that really crazy looking rhythm like this, because the heart just doesn't know what to do, and it just like, it's getting so much stimulation that it just freaks out. Okay. So like a tachyarrhythmia, a ventricular arrhythmia, VTAC, those are not good things. And then just kind of wanted to show it again, like visualizing it more extended. So here's like your SA node to the AV node, bundle of His, and then your bundle branches, and then your Purkinje's. Remember that the electrical potential can also bypass from the SA node to AV. It can also go through the good old bundle of Kent, so it can go around it, and then it can just go over and over. This is your global reentry. This is your Wolff-Parkinson-White. But not always. It can also cause like a supraventricular tachycardia. That can also be because of this global reentry. But Wolff-Parkinson-White is a type of global reentry. So this would come in, and then it would go over and over and over and over and over again. Or local reentry, atria, ventricle, wherever, and then you can get a precipitation of a tachyarrhythmia. So my question for you guys is, a patient is diagnosed with a supraventricular tachycardia caused by a reentry within the AV node. So we're in the AV node specifically. So remember, like I said, when we're in the AV node specifically, it tells you it's an AV nodal reentry arrhythmia. So an AVNR arrhythmia. You can extend the ERP, which you'll see with a lot of the arrhythmias. You can just extend the refractory period, or you can depress AV nodal conduction itself because it's through the AV node. So you're technically like slowing down conduction even more. You're kind of breaking that reentry circuit. So specifically this question, it's a reentry circuit within the AV node, okay? So my question for you guys, and you don't have to answer it, just explain how using a drug that increases the ERP of the AV nodal tissue can be used to abolish this tachyarrhythmia. And again, this is what a lot of the antiarrhythmics are doing, so we'll talk about that a little bit more, but this is kind of where we're going with the antiarrhythmics. But another thing I wanted to show you is you can do a Valsalva maneuver. So I don't know if I've showed you guys this in the past, but I don't remember if I have. I just think this is really cool. So I'm going to play it and explain it because they talk for a little bit. So this guy has SVT. He has a supraventricular tachyarrhythmia. So SVT, again, this is a global AV nodal reentry circuit, right? So with this, what they're trying to do is they're trying to do Valsalva maneuver. And they call it a modified Valsalva, and we'll talk about all the things that they're doing, but remember, there's 4 steps to Valsalva. We're going to review it here, but so he's going to blow out against a closed glottis. So he's blowing on just like a closed syringe. He does that for about 10 or 15 seconds, I forget. I'm trying to count. And then what they're going to do is you're going to see they're going to flip him. All right, come on, people. They're going to flip him up. So they're increasing preload, right? So this is, what is this from your, if you guys can remember from murmurs, from what the different maneuvers are, this is your leg raise. This is passive leg raise. The whole point of passive leg raise is to increase preload, okay? And then what's really cool is you can see here, here's his supraventricular tachycardia, right? Look at his rhythm. And then after a few seconds of this, they basically break the arrhythmia, and he goes back to normal sinus rhythm just by doing a modified Valsalva. So didn't even give him an antiarrhythmic. Just did this modified Valsalva maneuver. And the whole idea behind this is you're trying to, and we'll talk about like, I'm sure you guys don't remember Valsalva. Valsalva is a very like tricky concept, but by doing this, what they're doing is they're basically trying to slow conduction through the AV node. They're basically trying to trick the body into, they're not trying to trick the body. They're trying to like tell the AV node like, hey, slow down your conduction because we don't need as much, we don't need the heart to beat as fast, and that breaks the SVT. So with this, what other non-pharmacologic treatment could have been implemented here? I think this is too hard to answer right away because you need to remember what Valsalva does. You can also do the carotid massage. Anything that's going, remember that carotid, what is it? The baroreceptors, the carotid baroreceptor. If you do carotid massage, you also increase parasympathetic stimulation through the AV node. So these are like non-pharmacologic ways to treat SVT, but I wanted to use this as an example, as an opportunity to discuss the physiology of Valsalva maneuver, because this will come up like every block everywhere. So remember, there's four phases of Valsalva. Phase 1 is bear down. So this is in the past video. Okay, so it's 15 seconds. So he blew against that closed glottis. He was blowing on that syringe for about 15 seconds. What this is going to do when you're bearing down, remember, I forget if we did Valsalva like last year, and like we tutored on Valsalva, but by doing that, by blowing against that, I always remember like this is like when you're blowing, you're increasing that intraperitoneal pressure. It's going to push on the arteries. So this is actually going to increase your blood pressure. So that's the first thing that happens immediately, increase in blood pressure. And since we are increasing that intrathoracic pressure, you're also pressing on the veins. So you're going to decrease venous return. So we're increasing blood pressure, we're decreasing venous return. And again, this is like, think back to maneuvers. If we talked about Valsalva, like remember with maneuvers, you decrease venous return. That's the thing that's decreasing preload. And then since you're decreasing venous return, you're decreasing preload, the body's like, oh shit, like I need more blood. So you get this SNS response, the sympathetic nervous system kicks in because of baroreceptors, those pressure receptors, they increase the heart rate. Then you release it, so you stop blowing, your pressure's gonna go down like super quick, like immediately it's gonna drop because we increased it by blowing. Now it's gonna drop super fast, and it's quicker than the heart rate can go down. Like the baroreceptors, remember, they kick in pretty quickly, but it's not as quick as when you release Valsalva and then the pressure drops. Your heart rate's going to stay up for a little bit. It's like on high alert. And then when that happens, then with phase 4, everything kind of starts to go back to normal. So your venous return is going to increase. Your mean arterial pressure is going to increase. It's going to go back to normal. And then this is what you're trying to do with like the SVT, is the parasympathetic nervous system actually gets stimulated to now drop the heart rate. It's like, hey, I don't need this fast heart rate anymore. So it physically, the vagus nerve gets activated to drop that heart rate. And that's what's breaking the SVT. Pretty cool stuff. So that's basically what they're doing with that. You can also do a carotid body massage, just like, and that all that would be doing is this step of it. It's just, well, that's not a great circle, but that's what a carotid body massage is. You're trying to stimulate vagal stimulation. And again, it's enough to break the SVT. They did a modified Valsalva. They did this after the release before phase 4. They did what's that called? The leg raise, the passive leg raise. And that's also a maneuver. Could have put that in here. It's also a maneuver. That's the whole point of that, is trying to increase preload, try to increase venous return. So it just like kind of helps break the SVT quicker. So usually they try to do this before they give like an antiarrhythmic, unless the patient is like really, really struggling. But you saw like he looked kind of, if you watch the video too, like he looked kind of fine. And then he was obviously feeling a lot better after he broke the SVT. But just remember, like, this is the physiology of Valsalva maneuver. A lot of good cardiac phys that gets activated. And so, yeah, so SVT and Valsalva, again, a lot of the times, a lot of SVTs involve the AV node. A lot of SVTs are these AV nodal, like these AV nodal re-entry tachycardias. A lot of them, not all of them, but a lot of them are. And it's because, again, like I said, AV node is the most important node. Yes, the SA node's a pacemaker, but the AV, everything has to go through the AV node. And when you have these re-entry circuits, they're going through the AV node. They're not going through the SA node. So if you increase vagal tone, this can send an inhibitory signal to the AV node. Hey, like, let's slow it down. And then by doing this, you're aborting the arrhythmia because you're basically stopping the amount of excitable tissue that's present. You're basically slowing, like now it's slowing down enough where when, even if it is re-entrant, it's not going to touch excitable tissue, and then you can't have a signal. Modified Valsalva, we talked about this, the venous return just increases. A lot of the time this doesn't work. Especially the carotid sinus massage, it really doesn't work. And then you just give adenosine, or you give like an antiarrhythmic. And we'll talk about it. Adenosine is really good at slowing AV nodal reentrant. It's really good at increasing vagal tone on the AV node. So a lot of the times that's given. You can also give digoxin if you really want to. Or you can give beta blocker or a calcium channel blocker. They usually all increase parasympathetic stimulation to the AV node. And perfect segue into, this is what antiarrhythmics do. So antiarrhythmics basically break reentry circuits because we're basically trying to extend, we're trying to make it so like when the reentry circuit comes back through, it's going to hit a part of the action potential that you can't excite anymore. So class 3s, for example, these are really, really good at these reentrant tachycardias because these block potassium channels, so it's going to extend the ERP. And again, we're going to talk about this in more detail. And then your class 1As, class 1s, they block sodium channels, which, as you know, are not involved with potassium channels, but the 1As specifically also block the potassium channels. And anytime you block potassium channels, automatically you're extending the ERP because you're making this action potential be longer. So again, if you're making it longer, you're extending the absolute refractory period, you're extending the effective refractory period, the relative, you're extending all those refractory periods. But the main one that's going to help with not allowing another like activation depolarization is the extended refractory period. And then this is kind of like I wanted to just kind of show visually, like, again, if I give like an antiarrhythmic, if I'm increasing ERP, when the re-entered action potential comes around, it's going to come across tissue now that's not excitable. And that's a huge deal because you can only get these after depolarizations if you have excitable tissue. So for example, here's like in the absence of the drug, there's that unidirectional block. Let's say that this is like another bundle branch block. So it goes around, it splits, and then this goes and kind of does the rest of the heart. So it's fine, but we have reentry. And here's your reentry over and over and over and over again. And that can precipitate VTAC, which is very, very bad. And again, a lot of the times the unidirectional blocks is something like ischemia. That's usually what causes a block. But again, this can happen anywhere in the heart. But let's say we have this patient with the ischemia, but we give them like a class 1A. I want to say 1A. We give them like a class 1A because that's going to block your potassium channels as well. And then that's going to basically make this now unexcitable. You're going to abolish this unidirectional block. It's even if it comes back around, it can't activate another action potential because now the action potential is out here and you can't hit it. You can't start another action potential when it's all the way out here. Okay. All right. Lots of stuff. All right. Antiarrhythmics. We made it. So hopefully this will all be a cakewalk. Do you guys have any questions before we jump into the drugs? Because a lot of the times now it's just memorizing what the different classes do and then some names. But hopefully it makes sense now. Cool. All right. So I'm going to start with class 1 and class 3s. And there's a specific reason why I'm starting with class 1 and class 3. I always lump the class 1 and class 3s and then the class 2 and 4s. Here are the nodal action potential, contractile cell action potential. These are just like absolute need to knows. Like you just need to know what each looks like, the ions, we talked about that. So this is what I was mentioning from before. This is happening so quickly, like through those gap junctions, that if you were to overlay like the pacemaker and then like this nodal action potential and this action potential, this contractile cell action potential, they look like they're happening at the exact same time. That's what you want, right? We want the pacemaker, like we want the heart beating all at once. It's just hard for us to kind of like visualize it because it doesn't, like our brains can't think that fast, but it's happening that fast. So if you overlay it, this is kind of what it looks like. And I have a better like labeled one later, but I just kind of wanted you guys to see like the overlay. Okay. So in terms of like bringing EKGs into this, because a lot of the times with EKGs, it's going to be like what's happening to the EKG on these various antiarrhythmics. So kind of like a good way to think about it is here's your contractile cell action potential, right? So we have sodium, calcium, potassium, all throughout here. You can think of this action potential as this is the electrical signaling of a single myocardial contractile cell. So this is one single cell. And then phase 0 is depolarization of one single cell. But like I just said, it happens at the exact same time as all the other cells because of gap junctions. So it's going to happen really, really fast. So a better way to kind of get an idea of what's happening with the contraction of the entire heart is to look at an EKG. And that's why people look at EKGs, because that's what's happening with all of the cells in the heart. So you can think of this as like this EKG is what's happening, the electrical signaling of hundreds of thousands of myocardial cells. And then if we want to line it up, the QRS complex, we know that this is ventricular depolarization. Well, you can think of this as hundreds of thousands of phase zeros. Hundreds of thousands of phase zeros lines up with the QRS complex. Okay? And then the QT interval, you'll see like, oh, like the QT interval was extended or it's prolonged QT interval. All that tells you is that phase 0 to phase 4 of one single cell is now prolonged. So the Q to the T interval of all of the cells is prolonged. That means something is happening that's making this prolonged, okay? So you can look at QRS complex to look specifically at depolarization of hundreds of thousands of cardiac myocytes, and you can look at the QT interval to look at this overall action potential of single myocytes. It just kind of puts it into like, okay, well, what's happening with all of them in the entire heart? But usually what's happening with one is what's happening with all of them. So if I look here, if I'm going to give a drug that's going to slow depolarization of the myocyte, so I'm slowing depolarization, I'm slowing phase 0 of one single myocyte, that's going to slant, it's going to make it look slanty, right? Because again, if it's happening super quick, it shoots up. If it takes longer to kind of depolarize, it's going to look more slanty. It's like, okay, like, yeah, it's going to take a little bit longer. But like I just said, if we correlate phase 0 to an EKG, it lines up with the QRS complex. So if I'm taking longer to depolarize this cell, I'm slanting this phase 0 line, it's going to look like a widened QRS complex. And a widened QRS complex, this is what a lot of the class 1s do. A lot of the class 1s affect depolarization of your contractile cells, and that's going to widen your QRS complex. If I want to slow repolarization, so I want to extend that effective refractory period, I want to extend phase 3 basically, I'm going to make this look now not like that. It's going to look more like this. So it's going to be a little wider. That's going to extend your QT interval. Okay. So a lot of the class 3s and then your class 1As, like I mentioned, widen the QT interval, just being on the drug, because that's what it's trying to do. It's trying to make this action potential last longer. Okay. So your class 1 and class 3s, these are your rhythm controllers. That's why these are always kind of, these are the ones that are always lumped together. And by saying rhythm control, it's affecting like how the heart is beating, right? Because arrhythmias is like you have like the heart is contracting weird. The contractile cells are just contracting weird. It could be because of a reentry circuit or whatever. But there's something's happening that's affecting the contraction of the cells. So what type of action potential should we look at with class 1 and class 3s? Your contractile cell action potential. That's why your class 1 and class 3s affect the contractile cell action potentials. Your class 2 and class 4s, these affect your nodal cell action potentials because these are affecting the rate. So we'll talk about them after. Those are a little bit quicker. These are your rate controllers because those are going to affect, just try and slow down the rate of the heart. So they're going to slow down your sinus node as well as your AV node. Okay, so we're talking about class 1, class 3. So we're primarily talking about this action potential. So now class 1s. So class 1s, these are your sodium channel blockers. Every single class 1 is going to block sodium channels in some way, shape, or form. Like we just mentioned, since we're slowing phase 0, we're basically slowing depolarization. That's going to widen your QRS complex because, again, phase 0 of one cell lines up to the QRS complex because what's happening with one cell is usually what's happening with all of the cells, and QRS tells you what's happening with all of the cells. Like I said, class 1As can also extend prolonged repolarization. It's just like a fun fact. So you would expect a widened QT interval with your class 1As, but we'll go into that. 3 types, class 1A, class 1B, class 1C, and then there's this concept of use dependence. So this is like, I wanted to bring back chapter 1 Costanzo because I feel like people skip it, which is fine. I skipped it until like pre-dedicated, and then I went back. But chapter 1 Costanzo basically just tells you how like receptors work. And sodium channel, ion receptors work like this. So sodium channels, potassium channels, calcium, not so much calcium, but sodium, potassium, chloride, like those guys, they all work like this. And with this, there's 2 gates with channels. There's an activation gate and an inactivation gate. And depending on like the source, they have different names for them. They might be called like M gates and H gates. But one's an activation gate, one's an inactivation gate. And I bring this up because some antiarrhythmics are like good at binding to resting or like, yeah, like different, not even just class 1s. Like some antiarrhythmics, it's like, oh, it binds to resting channels. Or it's like, oh, they bind to open or inactivated channels. And this is what they're talking about. It's like the various ways that the sodium, potassium, chloride, whatever channels are opened. So what I mean by that is if I have a resting channel, so this is like resting. So this would be at like resting membrane potential. This is like when the cell is completely at rest. The activation gate is closed and then the inactivation gate is open. So it's closed, but it's like available. This is resting. This is like a true resting position. And we'll talk about it when we get to class 3s, but the class 3s bind potassium channels that are resting. The class 1s bind to sodium channels that are open or inactivated. Okay? So all that means is that the M gate is open. Doesn't matter what's happening with the H gate. If it's open or inactivated, that means that the class 1s can bind to these sodium channels. It like knows that this is now a channel that it can bind to. Okay, so it doesn't matter what's happening with the inactivation gate because, again, it's not inactivated. They're open or they're inactivated. They're completely like just this is open. Okay? And so this concept of use dependence means that class 1s will bind to sodium channels that are in use, aka open or inactivated. The activation gate is open. Okay? So these are the 2 that the class 1s are going to bind to. And I bring that up because on a myocardial action potential, where are the sodium channels open or inactive? So they're open, which hopefully makes sense, during depolarization. So they're open here. And then they're inactive, which is this one. They're inactive, where they're not closed yet, but they're like kind of starting to like go to resting. They're not resting, but they're starting to go to resting. This is where they're inactive. It's kind of like around this area here, kind of, sort of. A little bit into the 3. And then eventually they completely go back to resting. That's your phase 4, right? So you can imagine with class 1 antiarrhythmics that have use dependence, aka they're binding to sodium channels in use, they're binding to sodium channels here and here, okay? And then all the class 1s, they have different strengths of use dependence. So like class 1Cs have really, really, really high use dependence. So what that means is they're amazing. They're amazing at binding to these types of sodium channels. Amazing. If there's a sodium channel that's open or inactive, class 1C is bound to it. Class 1As, they're like intermediate use dependence, means that there's like, they're good at binding to it, but they're not as good as 1Cs. And then your 1Bs have very, very low use dependence. So you can imagine like they're just not great at binding to sodium. And you're like, well, that makes no, why would you have like a sodium channel blocker that's not great at binding to sodium channels? We'll talk about that. Class 1Bs are only given in like very special cases of arrhythmias. But your class 1C and your class 1A, those are like the main 2 that exhibit use dependence. But since class 1Cs have very strong use dependence, you can imagine like the upstroke of phase 0, because remember, all of them are going to kind of look slanted. It's going to be very drastically slanted if you give a 1C versus a 1A. It's going to be less slanted because it's intermediate use dependence. So there's going to be like a more moderate like slope compared to this very drastic slope with a 1C. Okay, and then if we kind of look at this with like an EKG, so here's where, so where on an EKG are sodium channels open or inactive? Right here. They're open or inactive here because remember, they're open here and then they start to become inactive with phase 1, phase 2, and phase 3. So this is really where sodium channels are open or inactive. And I point this out because class 1 antiarrhythmics are really good to give to patients that have tachycardias. And hopefully that makes sense after seeing this, because a tachycardia, you see tons and tons of QRS complexes, right? They're just everywhere. It's like, boom, one here, one here, one here, one here, one here. Like that's what a tachycardia is. It's just a quick heart rate from R interval to R. The R intervals are really close together because it's like you're happening, like the beat's happening super quickly. So with that being said, since they're good at binding to the where sodium channels are open or inactivated, which is basically where QRS complexes are, they're really good to give if there's more QRS complexes. So if there's more places to bind, that's when they're really good. So all this to say, class 1s are good to give in a patient that has a type of arrhythmia that's causing a tachycardia. And then since 1Cs bind super, super strong, those are the easiest to see any sort of toxicity with. So when we talk about like toxicity with the different types, like the class 1As, the class 1Bs, and the class 1Cs, the class 1Cs have the highest toxicity. And they're actually not really used that much anymore because of the toxicity, but we'll talk about that. But does this make sense? So it kind of like the whole idea of use dependence, hopefully that makes sense. It's binding to these sodium channels that are open or inactivated. They're just in use in some way. The M gate is open. Okay, now the specific ones. And I want you to notice, like, especially the slant. Because when we talk about, like, the 1Cs, you'll notice, like, the slant for this guy is going to be, like, all the way out here. Because it has that really high use dependence. But for 1As, your 1As are going to bind. So, again, the normal is in blue. What the antiarrhythmic is doing is in red. So, it's blocking sodium channels. And 1As have moderate use dependence. So, it's like you're going to see, like, a moderate decrease in the upstroke. But class 1As also have that weird thing where they also can block potassium channels. It's really weird. This is what your class 3s do. It's just something to know that class 1As also do that. So you're also going to see an extension of the effective refractory period with class 1As. And it's only 1As. It's not all class 1s. So quinidine is an example of this. Procainamide is an example of this. I highlight procainamide because that's like, you should know the names of these, like, and like quinidine, procainamide, you should know that these are class 1As, but procainamide is like, if it's in orange, you need to know that it's a class 1A. So then thinking about like an EKG, if I'm blocking my sodium channels, I'm decreasing how quickly phase 4 is happening, that's going to prolong my QRS complex. But since these have that special blockage of the potassium channels, I'm also going to see a prolonged QT interval, which you'll see this a lot with the class 3s, but you also see it with the class 1As. Moderate use dependence, we talked about it. And again, we already talked about all the arrhythmias that it can be given for. These are really, again, these are going to be really good to give for any type of just tachycardia, like a tachyarrhythmia. So supraventricular arrhythmia, ventricular arrhythmia. Class 1As have side effects. Sketchy goes into kind of detail of these side effects, but you can see like synchrontism, I can't pronounce it, but like tinnitus, headache, dizziness, like that type of stuff. It can also cause thrombocytopenia, just like weird side effects. And also because we do have a prolonged QT, you can precipitate torsade de pointe. And we're going to talk about this a lot later, like with the class 3s, because all of the class 3s can precipitate torsade. But you have to remember class 1As also extend that effective refractory period, also prolong the QT interval. Now you can also get torsade with that. But wanted to talk about drug-induced lupus. Like I told you, well, I don't know if I told you guys this, but this is like you need to know drug-induced lupus for your exam. Procainamide is a class 1A, and it can cause drug-induced lupus. Some sources also say quinidine can do this. Just keep an eye out on it. Procainamide 100% does it. Quinidine might or might not. And then there's two other drugs that isoniazid, this is like a TB drug, so that's not really relevant for this block, but hydralazine. And hydralazine is an antihypertensive drug, so it's going to be relevant this block. That can also cause drug-induced lupus. And drug-induced lupus, exactly the same as lupus, so that would be like this patient would present with like the butterfly rash, the rash everywhere, the joint pain and anemia, and can also have a positive ANA. Which is, again, like I said, remember we talked about with ANA, it's really non-specific to lupus. It's really sensitive for like a lupus-like syndrome. So you can't diagnose with an ANA. But let's say you think that this patient has lupus, so you try to run up the normal antibodies, like the specific lupus antibodies. So anti-Smith, anti-double-stranded DNA, anti-whatever, like those other more specific ones. Those are all going to be negative. What's going to be positive is antihistone antibodies. And this is drug-induced lupus. If you have antihistone antibodies that are positive, that's your drug-induced lupus. And you don't have to treat as if they have lupus. You just stop the drug. It'll go away on its own, like how it kind of is starting to do in the second panel of pictures. Okay. Class 1Bs, so these guys are lidocaine, mexelantine. These, like I said, they have very, very low use dependence. And you're like, okay, like, why is it considered a class 1? It still binds to the sodium channels. It's just really bad at binding to it, like during the upstroke. It's really bad at binding to sodium channels during the upstroke. So you might see like a minimal, like even in this picture, you kind of see like a minimal decrease, like the very small decrease in like the QRS complex, in the upstroke. It's not enough to change the QRS complex at all. But what you give 1Bs for is if you have a decrease it'll actually decrease the QT interval. It'll actually make the effective refractory period earlier. And the reason why is because I'm going to jump down here. You really only give, why would you want that, Nay? Yeah, exactly. Why the heck would you want to give a drug like this to a patient with an arrhythmia? You're like, that's the exact opposite of what I just taught you, what I just spent like a half hour explaining. You really only give class 1Bs for ischemic ventricular tachycardia. This is really the only time. I even asked my brother, because he's an ICU nurse, right? I'm like, do you give like lidocaine or mexelantine for like anything else? And he's like, no, like you really only give it for a patient that like just had an MI and now you like don't, and now they're having like a ventricular tachycardia. So again, there's still a tachycardia. All the class 1s are good to give for tachycardias. But specifically why we're decreasing the extended refractory period and like why we would give this drug is, I don't know if you guys have like went over like ST elevations and ST depressions, but if you haven't, basically what's happening with like ST elevation MIs and like ST depression MIs is if you have complete ischemia, so like an STEMI, an ST elevation myocardial infarction, that is a complete ischemic heart attack basically. With ischemia, more myocytes are already depolarized. So think about them being like closer to the action potential threshold. So instead of being at like -65 or whatever it is, -85, I don't even remember what it is. They're closer to like -40 or whatever it is for depolarization. They're already closer. It's just a function of like truly ischemic cells are already closer to a depolarized state. Okay? these drugs, these class 1Bs, are super good at binding to sodium channels that are in a completely depolarized state, which is right at the peak of the QRS complex. And then as soon as they leave this depolarized state, so as soon as it starts leaving, I know this isn't a QRS complex, but it's right at the top here. And as soon as it starts leaving that completely depolarized state, that's when the drug stops unbinding. And it actually causes the action potential to occur quicker. Like with this with these cells being depolarized already, it actually causes the action potential to happen quicker. So if we give, and it actually it helps, it would actually cause them to go into like this ventricular tachycardia. What you're trying to do with this is you're trying to bind those sodium channels that are already depolarized. You're trying to break the arrhythmia that way by binding to those already depolarized sodium channels. Okay. So this is kind of like, again, you give it for a tachycardia because there's a faster heart rate, there's less chance of it to unbind, but you give it for ischemic tachycardias because these drugs are really good at binding just right up here. And if they're binding to those sodium channels right up here, they're just helping to break this very specific type of arrhythmia. Okay, it's a very, very specific case. If it didn't make sense, we can go over like in a future lesson, like with EKGs, with like ST elevation, MI, like we can go back through that. Yes. So, and we will talk about like, so the question, like sudden death for ventricular tachycardia after an MI. Remember, like after an MI, the number one cause of death is an arrhythmia. Like that's like people don't actually die from the MI, they die from the arrhythmia that they go into after the MI. And we'll talk about it with like your beta blockers. Your beta blockers are, you need to give a beta blocker to anyone that had an MI. Like you have to, and we'll talk about it. But also you give a 1B. You give a class 1B antiarrhythmic because you don't want this patient to go into ischemic ventricular tachycardia. So you're trying to break the arrhythmia before it even happens. And like I said, before we go, if it's still like not clicking, we can talk about it like in the future. But it's just understanding that if you have ischemia, the cells are already basically closer to being depolarized. And these drugs are really good at binding to sodium channels that are already depolarized. So they're going to specifically bind to the ischemic tissue. And if you're specifically binding to this ischemic tissue, it can't break into like a ventricular tachycardia. Okay? It's kind of confusing, but this is a very niche drug. This is really only given after an MI because these drugs are really good at binding to ischemic tissue, like the sodium channels of ischemic tissue. Okay. Okay. And then your class 1C, so this is your flecainide, propafenone. These, look at this slant, super slanty, super slanty. This has super high use dependence. You're going to see a super widened QRS complex. That's not always great though. So this is what I was saying, like class 1Cs are really not given anymore because they have they just have crazy use dependence. So like they bind incredibly strongly to these sodium channels. So that's going to markedly widen your QRS. And if you widen the QRS, that increases the risk that now that the rhythm is going to become arrhythmic. And yeah, arrhythmic. So now it's like an antiarrhythmic is like causing an arrhythmia. So they tend to stop like not giving 1Cs. But if they were to give a 1C, they only do it if like the patient has absolutely healthy heart, like an absolutely structurally normal heart, like nothing else is wrong with the heart. Because if the heart is normal to begin with, it's going to have a decreased chance anyway at like just breaking out into a random arrhythmia. So if you were to widen the QRS complex, it would be a little bit more protected than someone that has like already like it's a struggling heart and now you're widening the QRS. Like they're going to break out into an arrhythmia like at any second. So they tend to not give it, but if they do give it, it's going to be only for people that have absolutely normal hearts. Okay. And usually when they give this is like if you have like AFib or like any sort of like flutter, like any sort of like just weird, even flutter is like kind of weird to give this for because it's like this is a rhythm controller. But you can give this for like again any of like the supraventricular tachycardias, anything to kind of break an abnormal rhythm. And then here's your summary of your class 1s. So remember, your class 1A is quinidine procainamide. It's going to have moderate use dependence on the QRS, on the upstroke, also on the QRS complex. It's going to widen it. But remember, the class 1As also block potassium channels. It's a very class 3 type thing, but it also does it if a class 1A. So it's going to prolong the ERP. Again, this is very good. So the class 3s are good for reentry tachycardias through the AV node, but the class 1As are also really good for reentry tachycardias through the AV node because of this ERP prolongation. And this is why a lot of the times they tend to give like procainamide like almost immediately if someone is in like Wolff Parkinson White, or they'll just give a class or they'll just give a class 3. But they'll try with like a class 1A. I think quinidine or procainamide actually is first line for Wolff Parkinson White, and it's because of this extension of the ERP. It really has nothing to do with the sodium channel blockage, but you can give it for other reasons that you want to prolong the sodium channel, like the sodium channel upstroke. Class 1Bs, remember, you might see an effect on the QRS complex, usually not, because it really doesn't, it has super low use dependence. It actually decreases the QT interval because it's decreasing the extended refractory period. And again, you really only give this post-MI for ischemic ventricular arrhythmias. And then your class 1Cs are super high use dependent. So they're going to really, really extend the QRS complex a lot. And then they'll basically, you only want to give this to like a very healthy heart. And that's your propafenone and your flecainide. Okay. All right. Good. So now class 3s. So class 3s, hopefully a little quicker. These, they're not all different, which is nice. So these are your potassium channel blockers. So potassium channel blockers, they're going to prolong. And this is like those questions that I asked you in the very beginning. Like if I block potassium channels, how is the action potential going to look? It's going to look like this. It's going to be extended. It's going to take longer now for repolarization to occur. But by basically taking longer for repolarization to occur, we're extending the effective refractory period. By doing this, we're prolonging the QT interval. And then class 3s exhibit reverse use dependence, which we'll talk about. And then all of the class 3s, as well as the 1A, can precipitate torsade. And anything that prolongs QT interval can precipitate torsade. So what is torsade? So remember, torsade is twisting on a point. So if we were to draw like a line exactly in the middle, like this isoelectric line, like exactly in the middle of this QRS complex, that it would be twisting around that point. I didn't draw it that great. That's all right. So these QRS complexes would be twisting around it. The other name for torsade is polymorphic VTAC, and that's exactly what's happening. We have various shapes to our EKG strip line, our QRS complexes, and it's because the ventricles have now went into a tachycardia. So they call it poly-VT, polymorphic VTAC, whatever. It's torsade. So if you're doing questions and you see polymorphic VTAC, just think that's torsade. Have this in your head. Again, anytime you can prolong QT interval, you get this. So even like the long QT syndrome, which is like an ion channel mutation, a potassium ion channel mutation, you can also get torsade from that. And this obviously leads to cardiac arrest. And you treat this with magnesium. We'll talk about why magnesium is considered a class 5 antiarrhythmic, because it basically treats torsade, which is an arrhythmia, right? So we'll talk about this later when we talk about the class 5s. Okay, and then what's reverse use dependence? This is why I went into like that Costanzo picture with all the channels. Reverse use dependence is it'll bind to channels that are not in use. So like true resting or closed. So the inactivation gate now is completely closed. The activation gate is closed. So both are going to be closed here. This isn't a great picture, but I just wanted to show one with like potassium. But this, just keep in mind, open, inactivated, and like resting is the same as closed. It's just anytime they're not in use. And hopefully that makes sense, because opening of these channels is kind of what leads to repolarization. So if we keep them closed, like if we bind to them when they're closed, we're keeping them closed. So we're prolonging repolarization. But remember with use dependence, they're binding, like if you were to look at an EKG, where on an EKG are sodium channels in use? They're in use phase 0 to phase 4. Where are the potassium channels not in use is where they're resting. It's going to be during phase 4. So what I mean by this is these drugs are really good. So you would give class 3s anytime that you have like bradycardia, so a very slow heart rate. And the reason why is because you would have longer phase 4s, like longer time period, so longer between like the T wave and the start of the next P wave. That would be a lot longer and a very slow heart rate. So they bind better in patients that are bradycardic. So again, if you have a bradycardic patient that you start with a class 3, they're at very high risk for torsade. Okay, so class 1s, they bind better at quicker heart rates because they bind this part of the myocyte, action, like this part of the EKG, this part of the myocyte, and then the class 3s bind when the potassium channels are resting, which is during phase 4. Okay, so these guys are sotalol, difetilide, and abutylide. Sotalol is also a beta blocker. We'll talk about that. The lol ending means it's a beta blocker, but it also is a class 3. All class 3s are going to block potassium channels, which is going to prolong QT interval. It's going to extend the extended refractory period, effective refractory period, all stuff that we've talked about. So it's going to extend this. So again, the whole idea here is to break reentry circuits so that you can't go into another action potential before it's ready, before it's excitable again. And then we talked about reverse use dependence. Again, just like we talked about with reentry circuit tachycardias, your class 1s, you can give them for any type of arrhythmia, any type of like weird arrhythmia, like an AFib or like a VTach. And then there's an increased risk of torsade that gets worse if you give it to a patient with bradycardia. So a bradycardic patient is at really high risk for torsade because, again, that's where these guys bind the absolute best too. I wanted to spend some time talking about amiodarone. Amiodarone is kind of, again, I asked my brother about it. Amiodarone is also the type of drug that all the doctors just give. Like if someone comes in with an arrhythmia, they just give amiodarone. And the reason why is because it has all class antiarrhythmic function. So it has class 3 function, so it's going to prolong the QT interval, it's going to block potassium channels. It has class 1 function, it's going to block sodium channels, so it's going to prolong the QRS. And then it has both class 2 and class 4 effects, which we're going to talk about next, but those are your nodal. These affect like the nodal cells specifically rather than like the actual contraction. They're going to affect now the heart rate itself. So amiodarone, they love giving amiodarone, and I think they love giving it so much because it has a really low incidence of torsade. So class 3s are great, like I just kind of mentioned, it's great to extend the effective refractory period, like that breaks most arrhythmias, but a lot of the times you're like basically precipitating torsade if you give a class 3 and you're not watching. Amiodarone is kind of like that drug that they can just give and like they don't have to worry about torsade. So it's super effective because it's affecting literally every single phase of this action potential. It's affecting this action potential as well, which we'll talk about next, the nodal cell action potential. It's affecting all of these action potentials. And there's a low risk of torsade. Sounds fantastic. So again, you can give it for AFib, you can give it for like a VTach, you can give it for any of the arrhythmias we've talked about. So what's the catch with amiodarone? Amiodarone's half-life is 58 days, so it's almost 2 months. So you give a dose of amiodarone, it's in the system for 2 months. Crazy. It's super, super, super lipid soluble. So all of the side effects you're going to see is going to be because it's building up in like these fatty organs within the body. So it's going to build up in the brain. We can see neurological side effects. It can accumulate in the liver, so you can see what's known as hypersensitivity hepatitis because we have increased LFTs because it accumulates in the liver. It can accumulate under the skin, called photosensitivity, so like you can go outside and be outside for like literally 30 seconds and get sunburned. It causes what's known as blue man syndrome, or like the actual like name for that is argyria. Argyria is like another name for blue man syndrome. It's just like a weird side effect. It doesn't actually cause any issues. It can also deposit in the cornea. So, and the reason why is because the lacrimal glands can actually secrete amiodarone, and it causes what's known as cat whiskers. I'll show you a picture of it. It's kind of weird. And then the number one issue with amiodarone is pulmonary fibrosis, and this is actually what causes death in patients that are on amiodarone. So all of these other ones are just kind of side effects, but it can actually cause pulmonary fibrosis, and that can cause death. Also, if you look at the structure of amiodarone, it has iodine in it, and as you know, anything that has iodine in it can cause either hypo or hyperthyroidism. So here's our amiodarone with the iodine, so there's your hyperthyroidism. Here's your blue man syndrome, your argyria, literally the patient just turns blue, really weird, photosensitivity, and then here are the corneal deposits, so the cat whiskers. This doesn't actually affect vision. So this is like, it's really important to know with amiodarone, a lot of these effects are not actually hurting the organ, except the lungs. So with the eyes, it's not hurting the eyes. It's just something, it would be like something you would note on physical exam. Like you see like these cat whiskers. It's not like patient's going to come in with like vision changes. Okay. With blue man syndrome, I always remember this guy from My Big Fat, no, what is it? Big Fat Liar? I don't know. Frankie Muniz, remember him? So you can think of him. He's on amiodarone. That's why he turned blue. All right. And then here's your pulmonary fibrosis. So they won't say patient presents on chest x-ray with pulmonary fibrosis. They'll never say that. So look for like terms like honeycombing. Honeycombing, it looks like there's like these patches of like air mixed in with patches of like not air. So that's like it looks like a honeycomb if you were to like do that with all of the patches. All right, I'm going to speed through class 2 and class 4s. Not speed through them, but they're a lot easier. But does that make sense with the class 1 and class 3s? We're affecting the rhythm. We're affecting the cardiac myocyte action potential, unless you're amiodarone. Cool. All right, last review, because again, I really want to emphasize this. Wow, you guys all really understand. Love that. Okay, so right now, we talked about this cell a lot with the last one, with the class 1s and class 3s. They affect the rhythm. So their rhythm, remember, is about how the cell is contracting. So now we're going to affect our rate. We're going to affect the rate of the heart. So as you can imagine, we're going to affect the nodal cells. Not only SA node, AV node, nodal cells that are located ectopically, so Purkinje fiber, wherever. So that's there. So this is what I was talking about. I had a better labeled one. So remember, your SA node, it looks like these are happening all super quickly at the same time, but remember, like, this can all be kind of superimposed on an EKG strip. Okay, so class 2 and class 4s, these are your rate controllers, sinus node, AV node, any nodal cell action potential they can affect. That's going to be here. So we're working with this action potential now. So the funny current, the calcium, and then the potassium. Class 2s, beta blockers. So this is like what everyone knows and loves as your beta blockers. They block beta receptors. And what they're doing specifically, how they're blocking these receptors, once you block, like when you're blocking the beta receptors, what that's going to cause is it's going to actually cause the cell to depolarize less frequently. So it's affecting the funny current. So you can see the slope of the funny current is like it's slower than normal because it's taking longer now to allow for sodium to enter the cell. And then not only that, it's not affecting calcium at all. That's your calcium channel blockers. So upstroke's fine. It's also, the beta blockers also affect potassium. Basically, it's going to take longer to repolarize. So there's like a longer, like a wider slope of the potassium channels as well. So these are the guys that end in olol. And the whole point of a beta blocker is to slow the heart rate. We're trying to affect the rate of the pacemaker cells. So by doing that, you're slowing the heart rate. You're also decreasing contractility. You're literally decreasing chronotropy. Remember, beta receptors are for like contraction. You can just imagine it with like the extrinsic control as well. Like if you want to contract more, you want to get more blood out, you're going to increase sympathetic, which binds to beta receptors. So beta blockers are decreasing contractility like that. And a lot of the times what this has overall is if I'm decreasing contractility, that means I'm decreasing the amount of work that the heart has to do. And I know like we're talking about nodal cells and like contractile cells. I literally just said we're not focusing on the contractile cells with beta blockers. But if I'm decreasing how quickly the contractile cells are contracting, like I'm decreasing the rate of this of like how frequently they're contracting, that's going to decrease the amount of work overall that the heart has to do, which is going to decrease oxygen demand. And if you decrease oxygen demand, this is going to make, like, for example, stable angina. Remember stable, I don't know if you guys have covered stable angina yet, but stable angina, what causes the chest pain with stable angina is because the heart is trying to beat and it doesn't have enough oxygen. So that increase in oxygen demand causes the pain. So beta blockers, the whole point of them is to try and decrease oxygen demand. They're trying to make the heart beat slower so that it's not trying to use as much oxygen, and then it's going to give away that chest pain, basically. Okay? So you'll see a lot of indications for your beta blockers on top of arrhythmias is like stable angina, for example. Some beta blockers are partial agonists. I underlined that in pink, just like a different underline color, but you need to know which ones are partial agonists. They're not going to tell you. So Pindolol and acetobutolol, I just put the structures here. I'm not really sure why. I just wanted to have something on the slide. But these are partial agonists, so which sounds super counterintuitive, but they're actually, not only do they block beta receptors, they actually partially agonize. And I don't know if you guys remember from like neuro, but some dopamine receptor blockers also are partial dopamine agonists. So it's just like a feature of some drugs for whatever reason. If I understood chemistry better, I would explain why, like just looking at the structure of these, but I have absolutely no idea. But you just need to know like they're partial agonists as well. So while you can give partial agonists for arrhythmias, you can't give partial agonists for stable angina because that's just going to make the pain worse. I mean, imagine trying to now make the heart beat faster when like that's what's causing the pain, the chest pain. So just something to keep in mind. So if that would be like an instance. A lot of the times they don't ask you like what drug would you give this patient. That this could be like a potential where they're like, which drug would you not give this patient? And they list one partial agonist and all other beta blockers that aren't partial agonists. Very quick review. So beta 1 receptors, like I said, they're found on the heart. So the beta 1 is found on the contractile cells as well as the nodal cells. They're also found in the juxtaglomerular apparatus. They're actually what's responsible for read and release. And we'll talk about this. This is why like you should give beta blockers with heart failure. We'll talk about why. Remember, this is a true beta 1. It's not a B. And I highlight that because we're going to talk about adenosine at the very end. And adenosine, they're A1 and A2, not alpha. Okay, so just something I wanted to point out. This is a true beta 1. So like thinking back to like your G protein coupled receptors, GPCR, whatchamacallit, like chart. This is beta 1, beta 2. Okay, so beta 1 is G alpha S coupled, so cyclic AMP is what's responsible for it. If you stimulate, you're going to get contraction, so it's going to increase both contractility because there's beta 1s on the contractile cells, as well as increase heart rate because there's beta 1s on the nodal cells. And obviously, if you want to increase the heart rate extrinsically, you can do so with the sympathetic nervous system. Norepinephrine, epinephrine bind to beta 1 receptors. Beta 2, I'm going to mention beta 2 because some beta blockers are non-specific to beta receptors, so they might have random effects of binding beta 2, even though that's not what they're trying to do. It happens because they're non-cardio specific. Beta 2 receptors are found anywhere in the body that there's smooth muscle. So the number one place that's relevant to this block is the smooth muscle surrounding bronchi. Okay, so just briefly on how these guys work, this is also G alpha S, but when it gets activated, cyclic AMP is going to inhibit myosin light chain kinase, and when it binds to and inhibits myosin light chain kinase, it's actually going to basically cause relaxation. So it's kind of weird because beta 1 is a G alpha S, cyclic AMP, it's all the same, but that causes basically contraction, it increases contractility. Beta 2 is G alpha S, it's cyclic AMP, everything's the same, but its net effect is relaxation. And you just kind of have to just kind of try and remember that with like the smooth muscle, like basically agonizing beta 2 receptors is a treatment for asthma to help remember like with the relaxation. And yeah, if you inhibit myosin light chain kinase, you're not phosphorylating myosin, you're decreasing the amount of myosin, and you need myosin to bind to actin to get a contraction, so decrease myosin, decrease contraction. This is like another just kind of what I just kind of mentioned. Like you can have the exact same thing, epinephrine binding to both beta 1 and beta 2, and you get contraction of one and relaxation of the other. It's just, remember, like we talked about with G proteins, it's cell type specific. This is another thing to know for sure, which ones are cardioselective. I did use the A-beam mnemonic. I think it's in Anki. I used this one. So atenolol, betaxolol, esmolol, acetabutalol, and then metoprolol. You just have to remember what the A ones are for here. And also remember, like, acetabutalol is a partial agonist. So you can't give it for, like, stable angina, but you can give it for, like, an arrhythmia that you want specifically targeting the heart. So these are your cardioselective ones. So these are going to be usually your first lines for an arrhythmia where something's going on with the heart. Metoprolol is usually given for that. Your non-selective ones, these are going to be more so for like, you can give for other random things where there are beta receptors present. So I don't know if you guys remember from Dr. White's lectures when he was talking about how he has glaucoma, he's on a beta blocker. He's on a non-selective beta blocker for glaucoma because if you, whatever beta receptor is present within like the eye, it makes more like fluid, and that's what's causing glaucoma. So if you block it, it's going to decrease the amount of fluid that's being produced in the eye. So it's just like a thing to remember, like you can give beta blockers, like if someone's on a beta blocker, it's not automatically they have something wrong with the heart. They can be on a beta blocker for literally any other reason. Okay. And then, like I mentioned, besides an arrhythmia, what can you also give beta blockers for? Stable angina is like the number one, but do not give the partial agonist. So no pindolol, no acetabutalol. And hopefully that makes sense. You're decreasing oxygen demand. Over here with HOCM, we'll talk about that. Well, we won't talk about that. I want to talk about this one last. But with HOCM, you give a beta blocker because you're trying to remember with HOCM, if you guys can remember from like the what's that called? The maneuvers. Remember what makes the murmur and hokum sound less, aka making it better for the patient, is if you increase the amount of fluid that is in the left ventricle. So you can either increase afterload, you can increase preload, but by increasing the amount of like just blood that's in the left ventricle, you're going to push this IV septum out of the way. And then now more can go up out to the rest of the body. It's going to make the patient feel better. So if you give a beta blocker, you're decreasing contractility, and remember that's if you decrease contractility, you're going to increase diastolic filling time, and if I'm increasing diastolic filling time, I have more blood in the ventricle after diastole. Okay, so that'll make it better. Acute MI, acute coronary syndrome, this is a non-negotiable need to know. I know I say like you need to know everything, but this is a non-negotiable. This was on all of my boards as well. You probably will get a question on this on board. They love to ask about like cardiac like indications and like preventative measures. They love to ask that, which you guys will do eventually in dedicated. But beta blockers, they did like this massive meta-analysis study where that if you give a cardioselective beta blocker after a patient has an MI, it like decreases their mortality and risk of sudden cardiac death by like 20% or something absurd after an MI. And we'll go into it because it's a really good physio review, but it's like you need to kind of get in the habit of like someone says like patient had an acute MI or patient has this acute coronary syndrome. What's like the first line drug I should give them? You give them a beta blocker before anything else. Even before like lidocaine or mixellantine, you give them a beta blocker. And it's because of this really, really, really reduced risk of sudden cardiac death following an MI if you put them on a beta blocker. And the reason why is because it reduces cardiac remodeling. So what the issue, so post-MI, obviously an MI means that part of the heart has died, right? We have an infarction. So remember back to like shock and hemorrhagic shock, what happens with hemorrhagic shock is like the kidneys are sensing that there's just not enough blood being released. Like there's just the heart, like if I have hemorrhagic shock, I'm bleeding out. It's like we need to reabsorb water, we need to increase sympathetic nervous system, we need to increase vasoconstriction, like we need to try and get blood to the organs. That can also happen after an MI. After an MI, part of the heart died, like let's say this part of the heart dies. Now you have this, like now the heart needs to pump out the same amount of blood, but we have less cells available to do it because they're dead. So it's kind of like the body thinks it's having hemorrhagic shock. So renin, angiotensin, aldosterone system gets activated, which actually just ends up making it worse. But one of the effects is, remember, the sympathetic nervous system gets activated, so norepinephrine gets released, and it leads to this cardiac remodeling. It causes this very eccentric hypertrophy, like left ventricular dilation that's occurring. So if you're not giving a beta blocker here to block this norepinephrine, it's going to just make the eccentric hypertrophy like happen quicker. So that's why they did this analysis to see like how helpful are beta blockers after someone has an MI, and they're like you need to give a patient a beta blocker after an MI. It's going to reduce the risk of them undergoing this cardiac remodeling in the future, and then eventually this is going to lead to heart failure. So it won't lead to heart failure as quickly. And there's many drugs you can give after, like you see here, like there's renin inhibitors, ACE inhibitors, aldosterone receptor blockers. These are all good to give, but beta blockers are like, they have been, that's why I wrote here, it has been shown, like they did a research study on this. So even though like, yeah, maybe all these other ones would help, beta blockers are the ones that you give. Okay. And then not only for the heart, they also block the beta-1 receptors in the juxtaglomerular apparatus, and those are the ones that are sensing, like, hey, like, remember these circulating catecholamines are going around, so this norepinephrine is going to go to the kidney and be like, hey, I need renin, I need more renin released. So then it goes through this process just over and over again, the RAS system just over and over again, it just makes it all worse. So you can also block these beta-1 receptors in the juxtaglomerular apparatus, which is going to decrease the amount of renin that gets released. And again, this is just really emphasizing like why the heck, like just think, it's kind of like, why do you give a 1B to a heart after an MI, like an antiarrhythmic to a heart? Why do you give a drug that decreases the extended effective refractory period after an MI? Why do you give a beta blocker to why do you give a beta blocker for heart failure? And I want to mention that this is compensated heart failure. This is not decompensated heart failure. That patient is they are unable to compensate. That's the whole point, right? They can't even pump out enough blood. Compensated heart failure is like they're still early in this process. Like they're still very early. Like, yeah, maybe they had this MI and like these cells aren't working as hard. or these cells can't work as hard now to pump out the same amount, but they undergo the renin-aldosterone angiotensin system. They undergo that. They're still able to, they have ejection fraction has been preserved. So, and that just causes some, concentric hypertrophy happens in the beginning to kind of make up for it. It's just to kind of preserve that ejection fraction. But over time, this happens. This is your uncompensated heart failure. Like, it can't beat anymore. So when it's talking about heart failure pathophys, like, why do you give beta blockers for heart failure? You're doing it to try and limit that remodeling. You're trying to not allow this remodeling to occur and that eccentric hypertrophy to occur. So this is kind of where beta blockers play a huge role in this process, because you really don't, anything that's going to just, it's the body's fault. The body thinks that it's in hemorrhagic shock. So it's activating SNS, it's activating renin-aldosterone angiotensin system. It's making it worse, but you can at least limit this remodeling by giving a beta blocker. Does that make sense? So it's really kind of weird to think you're making a heart beat less, even though it's, with heart failure, you're like, isn't it struggling to beat anyway? It's not uncompensated heart failure. It's compensated heart failure. You just don't want that remodeling to occur. Same kind of thing here. If that all happens, like, let's say like we had an MI here. So like, let's say we had an MI here, and now we have like, we're undergoing that sympathetic discharge. We're like basically here in this state right here. We have like the sympathetic discharge, and then we're in like this cycle over and over again. As we talked about, a huge indication of a huge thing that happens after MIs is an arrhythmia. So eventually it can undergo, if you're increasing the rate because of this SNS discharge, as well as increasing the amount of how much the SA node is firing, because there's beta 1 receptors on the SA node as well, you can lead to a cardiac arrhythmia. So with this, it's just really good to give a beta blocker. Block this, you'll block this, you'll block this, you'll decrease the likelihood of undergoing an arrhythmia. But like we mentioned, you can also not affect this process and just give like a 1B and affect the sodium channels, which is also fine. But you still need to give a beta blocker. That will like always be asked. And then side effects, they'll ask a little bit more about side effects compared to the class 1s and class 3s. They will ask about these a little bit more. So remember, and all the side effects are because there are beta receptors everywhere. And again, if they're not cardio specific, you can have beta blocking effects everywhere. So you can get fatigue, you can get dizzy. This is from like blocking the beta receptors on the heart. But you can also get, if you're a man, you can have impotence because there are beta receptors present that lead to that process. So if you block them, you can become impotent. So some people don't like taking beta blockers because of that. You can have GI symptoms, and then you really have to make sure, if you want to give a patient a beta blocker, that they don't have, that you're either giving them a cardio selective one, because if you block beta receptors and you give a non-selective beta blocker and you block beta 2 receptors on the lungs, if they have COPD or asthma, it's just going to make it worse. Because remember, beta 2 agonism causes relaxation, so if you block it, it's going to cause constriction, just like by default. And then the most important one to know is that it can mask hypoglycemia in diabetics. This is really important to know, and this will probably, if they asked about side effects, this is probably going to be the one they ask. So diabetics, basically what happens with diabetics, they can't control their own blood sugar, right? So they physically don't know, like they cannot, they know, you, for example, you can fast for like 12, 13, like you can do it. It's not great, but you can fast if you need to, because your body can break down glycogen, it can break down fatty acids, it can do stuff to kind of keep up your energy levels and keep the cells getting energy. Diabetics can't do that. They don't have that luxury. They can't just break down glycogen. They don't have insulin. They can't do this stuff. So when usually when their blood sugar falls, they know because they have a sympathetic discharge. Like they start getting sweaty, they get hot, they're like, oh my God, I need to eat. Like I'm getting dizzy, I'm getting fatigued, like I need to eat something, like my blood sugar is going down. If you give a beta blocker, you're basically masking that sympathetic discharge. So these diabetics might not even know that they don't have blood sugar because they rely so much on like those symptoms of hypoglycemia to now have some sugar. So it's really, really dangerous if you, like, they just have to kind of you have to just talk with them, be like, you have to set reminders on your own, like, you have to check to make sure that you have to check your blood sugar more commonly than not, because you're not going to have symptoms of hypoglycemia. So you're not going to know to eat. And then you're just going to pass out and go into ketosis like out of nowhere. So it's just something important to mention. This is like a really big thing that they would really like you to know. Okay. All right, and then calcium channel blockers, so also known as your class 4s, these affect the calcium, so the upstroke of the nodal action potential. But what's important to know is these block specifically the L-type calcium channels, so those, the L-type ones, those are the ones that are found both on nodal cells as well as on contractile cells. So just like beta blockers, these are affecting channels that are found on both nodal. I do have nodal here because that's their antiarrhythmic effect, but they also can block calcium channels anywhere else in the body, okay? But their intention is to decrease firing of the SA and the AV nodes. It's going to slow AV nodal conduction. And as we've been talking about now, if anytime you slow AV nodal conduction, you have a longer PR interval heart block. This is like a terminology thing. You do need to know the names, like which ones are we talking about for antiarrhythmic effects. We're talking about the non-dihydropyridines. These are the ones that are having that antiarrhythmic effect. So verapamil and diltiazem, these are your non-dihydropyridines. You can think of these as being like cardio specific. Dihydropyridines block calcium channels in smooth muscle, but like literally anywhere. And that's what I said, like calcium channels are everywhere in the body, just like beta receptors. So these are the ones that are going to have like way more effects. But since their primary target is in the smooth muscle, these have a really big vasodilatory effect. So if you're blocking calcium channels, you're not going to get contraction, you're going to get vasodilation. So these are the ones usually given for like hypertension. So nifedipine, amlodipine, nicardipine. I will say with these guys, these dihydropyridine calcium channel blockers, these guys you can have reflex tachycardia with these. And the reflex tachycardia has nothing to do with anything other than the vasodilation triggers the baroreceptors to think that you're losing blood pressure. So it triggers like very quickly your heart rate to increase. So it's called reflex tachycardia. It's totally normal. It just doesn't have anything to do with the drug. It has to do with like the baroreceptors thinking that the blood pressure is dropping. Okay, but your non-dihydropyridines, these are affecting the ones specifically in the heart. So verapamil, diltiazem, these are decreasing cardiac contractility because remember it's blocking the channels anywhere in the cardiac tissue. So nodal cells as well as the contractile cells. So decreasing contractility, decreasing heart rate, and then also it's increasing the parasympathetic, basically it's decreasing AV nodal conduction, just conduction through the AV node. So since it's doing this, you do not want to give a calcium channel blocker to someone that has heart block because you will literally kill them. You will literally slow down conduction through the AV node so much to the point where it just doesn't even make it anywhere else. And beta blockers also have like a very similar effect to the AV node. So you don't want to give a calcium channel blocker and a beta blocker to the same patient. You can usually mix antiarrhythmics, but you can't give like a class 2 and a class 4 together. And it's because of this heart block thing. So you can give these for something like AFib or A-flutter, anything where the rate is like just crazy fast for no reason. Something to note, and this is just like a fun fact, you can give these are rate controllers, right? So you can give these for AFib, but just remember with AFib, it's an irregular rate and an irregular rhythm. So you'll slow the rate down, but the AFib might persist. Like they might still have this really weird rhythm present. And that's fine. It'll still make them feel better because their heart rate's not going to be like fluttering like this with AFib. It's going to be good enough until you can now fix the rhythm. Like you have to like fix their rhythm, but like they're good to give to initially like calm the patient with AFib like down. But that's what it means when it says like AFib might persist. It might still be an irregular rhythm because these have nothing to do with rhythm. AV block, we just talked about it. Both of these slow conduction to the AV node. Digoxin does this too. Adenosine does this. We're going to talk about these very briefly with the class 5s. But as we know, beta blockers slow the upstroke, prolong repolarization. It's going to decrease conduction velocity through the AV node because we're now prolonging the entire action potential because we need the nodal action potential to move into the contractile cell action potential. So by prolonging just the entirety of the action potential, you're decreasing conduction through the AV node. Same thing with these calcium channel blockers. Okay, so just know that this is like just a complication that can happen with these rate controllers. And then class fives. So there's three class fives: adenosine, magnesium, digoxin. These are not real. It's not a real class. It's just they call them class fives because there's no other class they fit into. Adenosine, it's a nucleoside base. It's usually like, adenosine triphosphate, ATP. It's literally the A in ATP. So it is literally the same thing that's given for ATP. Its receptor is an A1 receptor, not an alpha 1 receptor. So I really want to emphasize that. This is an A1. It is a G protein coupled receptor, just like A2s, but they are not alpha receptors, okay? So these are not the ones that are found on like, your veins and your arteries. This is just an entirely own receptor special for adenosine, okay? So these are found so the A1 receptor is found in nodal cells, and then the A2 receptors are found on smooth muscle. Which I know can get confusing with alphas, but that's just what happens. I highlighted the A1 receptor because this is the antiarrhythmic effect. So here's kind of like a picture. So here's adenosine. It binds to both A1 and A2. A1 is coupled to GI. It's just a thing to memorize. And then A2 is coupled to GS. Okay, so down here, this is its antiarrhythmic effect. Again, these are found on any nodal cell. I know it doesn't show like the ectopic nodes like your ventricle, but this would technically be there as well. So by activating a GI, remember like cyclic AMP is down, and that's going to decrease chronotropy as well as dromotropy. So not only contractility, but also like, actual like how quickly, how conduction, and like what we've been talking about, conduction through the AV node. It's going to slow conduction through the AV node. And that's what's happening. If you activate, it's binding to and activating this inhibitory receptor, which is going to actively decrease the amount of cyclic AMP that's present, which decreases those things. So this is your antiarrhythmic function. It kind of acts like a class 2 and class 4 in that way. But it also has this other effect where its G alpha S gets activated, increases cyclic AMP, but in this case we have relaxation. So it's kind of like the beta 2. It's kind of exactly like a beta 2. You activate it and then you get relaxation. So they actually say you should always tell a patient that they can experience these side effects. Since it's just a vasodilator, they can get red, their face can get red, they can have flushing, they can literally feel lightheaded and feel like they're going to pass out. You just have to kind of tell them like, hey, you might have these side effects. Just keep that in mind. And it's because of this vasodilation effect. How it works, like how does it basically do this? Like what is it doing when it activates the A1 receptor? It's causing both hyperpolarization as well as blocking calcium influx into cells. So you can think of, okay, hyperpolarizing as well as blocking calcium influx. Again, it kind of sounds like both a class 2 and a class 4. It's blocking the calcium, like upstroke, as well as prolonging repolarization of the nodal cell. Overall, if I'm extending how long my action potential is, I'm going to basically be like slowing conduction through the AV node. I'm decreasing that chronotropy. The whole point of adenosine is trying to like induce a transient heart block, which hopefully makes sense. If I have an arrhythmia, it's going super, super fast. I'm trying to basically induce a first degree heart block to kind of slow it down through the AV node. Again, trying to slow it down so I extend the effective refractory period and I can't re-excite that tissue. And again, just wanted to show you, this is like something to tell people like when they're on adenosine, they cannot have any caffeine. Because it looks very structurally similar. This one I can explain with the chemistry, right? But it just looks very, very similar to how adenosine looks, like caffeine does, and theophylline. And this is a tie-in to this block as well, because theophylline is also, it's not really used anymore, but it technically is like a pulm drug. So just keep that in mind. If they mention these two drugs, like you can't give a patient adenosine. Because basically they're gonna like compete. Like they're gonna like compete for adenosine's receptor because they look so similar. But regardless, with adenosine, it's only usually given for like someone comes in the ER and they're feeling really not great. You give them adenosine. It's going to slow conduction. They're going to feel a lot better. So you only give it for very acute treatments because it doesn't last that long. It's like it kind of like gives you like a little bit of time to like buy more time to figure out what you want to give the patient. Magnesium, like I said, is considered a class 5, but really all you need to know is that it's the treatment for torsade. Like you give, if patient has torsade, polymorphic VTAC, you give them magnesium. And like the reason why is kind of weird, but magnesium is a divalent cation, right? It's a really, really tiny cation that has a 2+ charge. So is calcium. Calcium is also a divalent cation. So they look very similar. They look very, 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 very similar. So it can compete, and I'm putting this in quotations because it's not really competing with calcium. Like, it's not trying to bind to calcium's receptor, but it's like it's so similar to calcium that it can bind to its receptor. Like, it can. So it can actually affect like how much calcium is able to influx into the cell. So it can actually slow down. The depolarization phase of the nodal action potential. So it can kind of act like a calcium channel blocker. And then digoxin, we already talked about this, so we're not going to go into too much detail, but do know like both effects of digoxin. Don't get got with which one they're asking about. Typically, like more commonly, it's given for heart failure because increasing the strength of the contractility. I know I put in contractility. It's really inotropy, but it is increasing contractility, but it's really increasing the strength of the contraction. Its antiarrhythmic effect because it also increases parasympathetic activation onto the AV node. So it's slowing AV nodal conduction, and it's going to cause basically a transient heart block. Very similar to class 2 and class 4 and adenosine. Do you guys have any questions? I'm so sorry. That was a little bit longer. All right. I have like 4 questions. They're quick, I promise. They're like the U-World, not the U-World, the Boards and Beyond questions. I want to go through them because I want to yell at you guys if you get got. Okay, go ahead. I'll yell at everyone for you. Or you guys can do these on your own if you guys want to just do these on your own. But I do want to yell at you, so we'll do this one and then. But yes, have fun, Jay. Okay, well, this one, we'll do this one, and then since we went over, you guys can do that. They're not that difficult, which is good. But hopefully you can answer them after the session. Lidocaine, it's a 1B. Remember I said 1Bs have a very small niche of like when you can give a 1B. And remember with the class, so this is ischemia. Remember with the class 1s, when you give it with tachycardia, it increases the effect. It makes it better basically if you give it with tachycardia. The class 3s is with bradycardia will make it worse. So that's what it's kind of saying here. These guys preferentially bind ischemic cardiac tissue because again, when you have ischemia, they're you guys can let's do the rest then. If you guys don't mind, they're not gonna take that long, I promise. But with this one, remember, like I said, with ischemia, the action it's already closer to like the threshold, and that's just that's just what happens with ischemic cells. They become already depolarized. Okay. All right. Guys, I'm so proud. I am so proud. I didn't even have to yell at you. Did not even have to yell at you for getting got. Awesome. So I'm glad that I yelled at you. It worked enough. Good. MI, beta blocker. Then you can think about other stuff. But literally, anytime you see an MI question, just try and like automatically be like, okay, I need to give a beta blocker to this patient. Like that's what's gonna reduce sudden cardiac death. I think he talks about it here, like about the study that was done. Oh no, yeah. So they're a class one indication. So a class one indication basically means like if someone has an MI and you don't give them a beta blocker, you can literally get sued because of it's a class one indication. So it's like a medical malpractice thing if you do not give a beta blocker after an MI. And of course, there's other drugs. Like I think you can give any of these other drugs. You can give calcium channel blockers, probably digoxin, right? Because of heart, if they go into heart failure, sodium channel blockers, all those. But they haven't been shown like clinically to and like with this research study to reduce the risk of sudden cardiac death. Okay, I'm so proud. Okay, cool. All right. This is very much like what you will see on boards, and this is why I went into the action potentials a lot. Good. Perfect. Yeah, so this is again another thing like and I'm trying to get you guys in the habit of this for boards and we'll talk about this obviously when like dedicated comes and you're like board studying. A lot of the questions on boards is not only like, oh, which channels are affected. It's like what's happening to the channel? Are we affecting closing of the channels? Are we affecting opening of the channels? Is sodium flowing out? Is sodium flowing in? They love that, especially with like neuro questions as well. So just getting in the habit of like really forcing yourself to understand like what is happening. I'm basically blocking, I'm inhibiting opening of the sodium channels so they're blocked. That's a sodium channel blocker. Okay? So good. So this would be I would call this like a 1C. I would say that this is like a 1C because it's not a 1A because the potassium channels are not affected and then it's not a 1B because of 1B the upstroke wouldn't really even be affected. Cool. And I think that's what he says. Yeah, class 1C. Probably this would be a 1C. All right. I think two more. Nice and quick. Good job, guys. So these would be your class threes. So, and then when I say this stuff, just think like, okay, what were some of those names? I know we just went over it, so I'm not asking you, but like, okay, what were some names of the class threes that we talked about? Just get in the habit of that because they're not going to say class three antiarrhythmic. They're going to say like ibutylide was given or sotalol was given or something like that. Okay. And you just need to know like, okay, yeah, like that's a class three antiarrhythmic. Okay, good. And last question. Oh, you guys shouldn't know this. I think I brought this to you guys last year, maybe, or like, I forget. I forgot if I brought this to you guys. If not, you might just not know the answer, but do you remember we talked about if we ever talked about pufferfish, toxin? Maybe not, but it kind of, I put it in here because it was actually on the exam last year, I heard. So I put it back in here for you guys. It was on my exam first year as well, and I was like, what the heck is, like, I literally was like, what is, it was on my cardio exam first year, and I was like, what is this toxin? So if you guys haven't heard of it, it's called tetrodotoxin, if that still doesn't help. But it literally asked, my question first year was like, tetrodotoxin acts like this. And I'm like, what? Tetrodotoxin. You really might not get the answer from just the symptoms. I really did not know what this was. Yeah, nay, let's hear it. Tetrodotoxin. But just moving forward, if you see absolutely anything about a pufferfish, absolutely anything, and then they have these weird symptoms like blood pressure drops, respiratory rate drops. I think there's actually a oh, I forget. I think there's like a they did this in like a Simpsons clip, because I remember like someone was like, "Oh, they talked about this in the Simpsons," or like one of those like animated shows, and I was like, "What?" It's like, can you imagine getting a question right because it was in the Simpsons? Anyway, but if you see pufferfish, it's usually because like they went to this fancy ass restaurant and like the chef didn't prepare the pufferfish correctly, and then some of this they have to remove the tetrodotoxin from it. Um, if they don't, you can have these side effects and then literally die from it. And what tetrodotoxin does is it blocks sodium ions, basically. So it's kind of like a sodium channel blocker, but it's not cardio specific, obviously. It's going to decrease cell membrane permeability to sodium ions. It's basically blocking sodium receptors everywhere in the body, and that's why you see like effects everywhere. But that's what it's called, tetrodotoxin. So just keep that in mind. It's like a really weird sodium channel blocker. It's not an actual cardiac sodium channel blocker, but if you ever see tetrodotoxin, sodium, okay? Yeah, it's a fun fact. That's why I put it last, because I was like, oh wait, they shouldn't know this. Okay.